Okay.
problem. Just take your time.
I could have it with you.
Oh, you see that? I'm trying to see if I can see the class on YouTube.
The feed is yet to be um, sent to YouTube, so maybe within 5 minutes.
Okay.
Okay, Dr. Adonir, I think you can start.
Yes.
So as soon as you are okay, then you can start.
Yeah, I'm trying to get the YouTube.
Oh, okay.
Is there a particular link I can use?
Uh, Hello.
Yeah, hello.
Yeah, the YouTube channel is e-learning KNUST.
Okay.
The program is Pharm.
Yeah,
Is it one word
the
or
program is Pharm.
separated?
Yeah, e-learning
Okay.
KNUST. Yeah,
One word.
All right.
yeah.
Okay.
Hello.
Trying to share my screen with you.
Yes. I mean, it appeared for a while and went away.
Yeah, so yeah, but I think I'll move on to with just management of mood disorders. But before then, if there is any burning question that I should attend to, I'm more than happy to do so. Is there any burning question that I have to? And
Question.
good afternoon to everybody.
Good
Uh,
afternoon.
I'm
Good
happy to be
afternoon.
back with you.
We are too.
I'm happy to
You're
be back.
welcome.
I'm happy to be back with you.
Happy to
And
see you. Welcome.
thank you. If there are any burning questions, I think it's to be appropriate to bring them up now before I initiate the management of mood disorders, and then we'll move on to some other ones. So. Before we move on to anxiety disorders.
Dr. Dene is asking, I think there were some interesting questions that came in the morning. Some of them, Dr. Bochi asked you to defer it when, so maybe to just warm up, if you can remember.
Yes, I asked one question with regards to OCDs, whether there are classifications, whether there's mild, moderate, severe, or anybody with any symptoms is just summed up into one OCD. You said I should wait.
Well, there are modifiers or that can be used, but generally speaking, it's not classified as such. So, yes, you're right. There are some of the OCDs that are severer than others, but when the manuals, when you go through the DSM and ICD-10, would use what we call modifiers. Some of them will be mild, moderate, or severe, but it is not really a classification.
And from my end, I have two questions. The first one is in your practice where you use the TCAs or the selective what is the SSRO? Yes.
Mm-hmm.
So where you use the selective agents. And then the second question is practically, how do you go about diagnosing and monitoring patients?
Well, the first question I didn't get a question in the statement.
The place of TCAs in your practice versus the selective agents.
TCA is very much still very important in the management of various conditions. Basically, the proprietary use of or the proprietary indication for TCAs is an antidepressant, but TCAs can also be used as anti-anxiety, and then it can also be used in the management of sleep disorders. It can be used in other situations like childhood disorders, like enuresis or bedwetting, and so on. So it is very much a good medication still, but currently the SSRIs are less in terms of side effect profile, have been found to be milder than the TCA. So increasingly, we are using the SSRIs as first line mostly.
And then my second question was
the
on
second question about how do you go about diagnosing and monitoring? Diagnosis is an art. It's a science art, and you go through specific scientific steps, which we have structured, put together as semi-structured process or semi-structured interview and clinical examination from the interview. So this is the first and most important clinical semi-structured clinical interview and clinical examination form. In psychiatry, it gives us 90% contribution to your diagnosis. 10% or the remaining 10% will come from, you know, other further evaluations, and collateral informants. Collateral information. And investigations. When we talk about investigations, not CID investigations, we're talking about ancillary or laboratory investigations sometimes in a few cases. Okay, so this is how we go about diagnosing. So it's an art, and it is reproducible. It's this process is reproducible and it is reproducible and it is sensitive. So your primary diagnostic tool is your structured, semi-structured interview and examination. That's your primary diagnostic tool in psychiatry. I hope I've answered you.
Yes.
Yeah, I have a question. So with regards to the way that psychiatric conditions are diagnosed, I think from what we've learned so far, the three disorders, that's psychosis, anxiety disorder, and the mood disorders. For children, you can easily get a child with...
Let me stop you there before you complete. By now, I don't expect you to be saying psychosis. You should be saying psychotic disorders. Psychosis is not a condition by now. So I expect to start hearing that you are implementing what you are learning so far.
Yeah, so psychotic disorders. Anxiety can easily be identified in a child. So do we have children also presenting with psychotic disorders?
In fact, anxiety is probably one of the most difficult to identify in children. It's easy to identify psychotic disorders in children. All that we talked about yesterday occurs across the life spectrum from childhood to before you go to your grave. So it occurs across the life spectrum. Children as young as 2 years have been, and in fact now we even have techniques of diagnosing anxiety disorders, mood disorders, and a few other disorders in neonates. Have I answered you?
Yes, please. Thank you.
Good. So it can be, and don't be deceived. Anxiety disorders are really very difficult to identify in children. Children express anxiety in various ways, and it's kind of very difficult. Sometimes children may express anxiety by being hyperactive, or even by being irritable, or by being very, very unreasonable, or they be just going to throwing tantrums here and there, or express terror, and all of these may point to, depending on the context. Mind you, when you are evaluating a patient, you take into consideration the context of that particular patient. So the same presentation by two children would lead to may lead to two different types of diagnosis, because we are looking at the context in which we are making those, we are putting those symptoms in perspective.
Okay, Dr. Dene, it's almost 2 p.m., so I think you can start the main section now.
Okay, thank you. So we're looking at today management of mood disorders. But do you have any specific questions on the mood disorders from yesterday?
It looks like they are fine.
No.
Oh, okay. I heard a no, so go ahead.
Okay, today you can see us. Okay.
No, as in we don't have any more questions.
Oh, okay, good. So who can tell me how we manage mood disorders? Or how do you think we manage mood disorders? Yeah, I'm trying to get a response from anyone.
You can have a couple of options, in fact, in combination. So pharmacotherapy, psychological counseling and support systems. I don't know whether you'll consider spiritual interventions in your practice, but I would recommend that as well.
Why would you recommend that? Why would you recommend that?
I think that especially in our setting, the cultural, social, and belief system tends to blame everything on some spirits from somewhere. And I've come to realize that even when you find solutions, sometimes unless you back it up spiritually, people are not able to accept it as a feasible and a workable solution. So it helps, whether in reality or just by supporting the belief system. My thoughts.
But do you also would you believe that the same kinds of things expressed in Ghana are expressed, say, in Australia, but in different contexts?
Yes, I think I tend to believe that. Yes.
Great. So there is really no difference in the reality of the situation, whether the person is an Australian or the person is Ghanaian.
That's nice to know.
So that all I'm trying to say is that as scientists, there must be evidence. You must have the evidence to show that there is a proof of spirit in this. So without evidence, you cannot, based on an anecdotal.
Dr. Done, is there any way of finding out? Maybe
yes,
in your practice.
There is. Yes.
Can you share some of your experiences with us?
Yeah, so if you want to prove that there's a spiritual impact, you need to investigate, and you investigate by designing a research. Okay, now we would answer that question in this way. We would answer it this way.
He's going to answer.
We have the biopsychosocial. This is how we manage all forms of mental disorders. Biological management has to do with chemical agents. And chemical agents are medicines. And medicines, you guys produce them in the labs. Psychological interventions are specific therapies. can be support counseling. It can be cognitive behavioral therapy. It can be group therapy. It can be dialectic behavioral therapy. It can be individual therapy, individual psychotherapy, etc. So counseling in itself, counseling is just a subset of the whole psychological or psychotherapeutic intervention. So they're specific. Then you have psychoeducation. Social factors has to do with the environment. The environment, you can have, what are the environment? The environmental, the environment might be home, it could be school, it could be church, it could be a cultural environment, a cultural milieu. It could be social welfare systems. And here it could even be government comes in. You can have church, which would take into consideration the support from from the spiritual groupings that you belong to. All of these are analyzed person to person. So I've had patients where they tell me that, oops, the thing is gone off. How do I do that? Hello? Are you there?
Yeah, we are here.
Yes.
Yes.
Okay, all right. Okay, I'm back. I'm back again. I'm back online. I've had patients where the patient says, I won't take any prescription from you unless my pastor agrees to it, based on the person's belief system. Now the person says, unless my pastor comes in and prays over whatever. As a clinician, I will not deny that patient that opportunity. I won't. Because what is my aim? My aim is to get the patient help. So I will get a pastor invited, and I would have a session with the pastor and tell the pastor what the issues are, without compromising confidentiality of the patient. And that's one thing that we don't take into consideration in this part of the world, because you can be sued, you can be opening yourself up for lawsuits. You must balance ethical reasoning and approach to disclosure and privacy and confidentiality of your patient with reasonable limits of wanting to help the patient. So if the pastor would pray over my prescription that I've written and declare my patient healed, and my patient would believe that he or she is healed, but would comply with taking their medication to complete the healing process, I don't care what they ascribe it to. It's up to them. Once the patient gets well, I'm fine. So that is maybe what you were referring to as the spiritual component. But in terms of direct impact on the biology of the brain function and the deficiencies that have resulted in the condition, there is no evidence. But the evidence still exists that the same impact that our spirituality would have on the way we respond to, or the way the brain would react and respond, is the same thing if the person is not ascribing it to a belief system, but ascribing it to something else. The same thing, nothing changes. So, in terms of characteristics and the real nature of issues confronting the patient, it is just the same thing in different situations. The same wine, it may be in different wine skins. I hope you are getting it.
Yeah, it is clear.
It's clear now. Yeah. So these are the things that happen. So I asked a question about how would you manage mood disorders? And this same biopsychosocial. So with the biological agent, what kind of biological agent, in terms of broad categorization, do we use in managing mood disorders? But let me say that I want to discourage each one of you from polypharmacy. Polypharmacy should not be encouraged. Your best bet in any treatment is to start with one recommended and a good drug. Begin with the minimum allowable dosing for the age and weight group of the patient and the patient-specific characteristics in selecting your agent. And then you will titrate to meet clinical need. You titrate upwards to meet clinical need. And I'm going to take a few minutes to go through that aspect after you answered these questions. So you tell me, which broad group of medications or chemical agents are used in the treatment of mood disorders? Is Henry there? Henry 1.
I'll say antidepressants.
For the purposes of the treatment of mood disorders, I'll say no. Do you have any justification for saying antidepressants?
I mean, mood disorders include depression.
Yeah, that's a smart one. Yes, that is true.
So I was
But
thinking antidepressants will broadly, because you also said broad categorization. You didn't say you should.
Yeah, we are looking at mood disorders broadly, and we haven't identified that it's mania, bipolar, or depression. We're just saying mood disorders. All right, Henry 2. I can't see you, Henry 2. Where is it?
Yeah, I'm around. Oh, generally, because mood disorders it can be high or low. I also go the SRI, the serotonin reuptake inhibitors. can also help.
Those are antidepressants. They're just like repeating Henry one's response in another way.
Right.
Is Susan there?
Yes.
Kindly bail us out. I can just see the entire group. I can't see your faces still. So, but this is better than yesterday.
Okay. I think the mood stabilizing agents, you have lithium.
Great.
And you have the
Just hold it there.
Okay.
So all that I wanted was mood stabilizers. So in mood disorders, you use mood stabilizers as the primary agent. Now, you can give me examples of your mood stabilizers. Yeah, Susan, go ahead, please.
Lithium.
Okay. Lithium is the gold standard.
Okay.
But we will come to specific situations. So lithium salts. What else?
The anti-epileptics.
Yeah, anti-epileptic drugs. Yes. And then what else?
Oh, only me. Somebody just say something.
Yeah, you can pass it on to someone else. Who else would you
Isaac.
take as your lawyer?
Ike.
Oh, okay, Isaac. Ike.
Okay. So I'm very good at appointing people to help with the situation. I will add antidepressants, as Henry said. So,
all right, since you insist, I will add it. Yeah. Okay, and then what? Which other category of drugs can you add?
Then we have benzodiazepines.
In what way does benzodiazepines treat mood?
The atypical antipsychotics.
Okay. Great.
Atypical antipsychotics.
Yes, atypical antipsychotics. And is it, who is speaking? I can pick up the voice, but I'm trying to put the name to it.
It's our consultant.
Who just spoke?
Grace.
Grace, yes. It kept popping up in and out. Grace, why atypical antipsychotics? Tell me.
They have a mood elevating components based on their action, the antagonism of the H52A.
Is it mood elevating?
Or enhancing?
Just limit yourself. They have mood stabilizing properties.
Mood stabilizing properties.
Okay, so top on the list, which one?
Quetiapine.
Give me a name. Quetiapine is somewhere in the middle.
Olanzapine, aripiprazole.
Olanzapine is top on the list. You have quetiapine, aripiprazole, and what else?
Risperidone.
Risperidone is at the bottom, but it is still there. So these are antipsychotics, and we say that they are mood stabilizing also. All right, so these are the categories of drugs that we use in the treatment of mood. We use these drugs. Now, lithium is used in what situation?
Susan?
Grace here.
Grace, yes.
It's used in both acute maintenance and maintenance phase.
For which condition, specific one?
Mania, bipolar.
Yeah? Bipolar, that's number one. Bipolar disorders. Bipolar disorders. It is the gold standard. is the gold standard. But lithium is a specialized drug. And that is why you, as community pharmacists and specialized mental health pharmacists, must ensure that whichever patient comes to you with a prescription, is being prescribed by the specialist who knows how to use the lithium. And before you put a patient on lithium, the patient is prepared. There's a workup for patient. And that workup includes what? I want someone to volunteer. Otherwise, I'll start mentioning names.
Japan, TD. Japan, it includes therapeutic drug monitoring.
No, Japan, that's not. I'm saying there's a workup. You don't just start putting the patient on lithium. You have to do a workup before. And if the patient's characteristics are okay before you start putting the person on lithium. Just like you don't just get up and put somebody on clozapine, as we mentioned yesterday. Clozapine is a specialized drug.
Can I add a little? Is
that Grace?
Yes.
Grace again.
The workup, you have to take the patient's weight.
Which should be weight, done for all pressure, patients.
The electrolytes, renal function.
Okay. Right. I want you to tell me specific ones. So renal function, key. And why would you do renal function?
Lithium can affect the renal function.
How?
It competes with sodium in the part of the nephrons, the tubules. And dehydration.
One simple reason. Tell me this in a Viva, you would get 0 for this answer. In a Viva, I won't give you a mark for it. At the level of Pharm, I won't give you a mark for this. Who can give me an answer? Why renal function?
It interferes with the aldosterone system.
Nope.
I want to try.
Please do. And the name is Docas, yeah?
Yes. Is it excreted renally? So in impaired renal
function. Excellento. Excreted by the kidney.
I was just going to say that.
Hey, since when? Since when were you just going to say that? Who said it? The only critical reason is that it is excreted exclusively by the kidney. Of course, it will interfere with one so, but the key reason, the number one reason you mentioned, and mind you, when you're answering questions, your number one reason carries more weight in any scientific endeavor, in any scientific field. When you ask a question, you put your strongest first. The rest are deemed to be supporting. So if you put excreted by kidneys as your last afterthought, you don't get a full mark. You actually get less than 1/3. So the key reason is that it is excreted by the kidneys. Okay. What other workup laboratory? In fact, the workup I'm talking about are laboratory screening. So for you to use lithium.
Please, I want to ask a question. From what we learned this morning, we also got to know that in hyponatremia, that can also lead to lithium toxicity. So with the renal function test, aside the excretion, can we say that the sodium level or the electrolyte sodium specific level that you get can also give you an idea that patients can have that?
Well, the electrolyte level will tell you about how well the kidneys are functioning. The kidneys are supposed to maintain electrolyte electrolyte homeostasis. Okay? The kidneys are supposed to maintain electrolyte homeostasis. So the fact that there's electrolyte imbalance in itself might not mean anything other than that the kidneys are malfunctioning. The key thing to show that the kidneys excretory function is good is what we call the GFR. So you look at the GFR. The GFR is actually directly related to how well the kidney is excreting or pushing things out. Then the electrolyte homeostasis state, the status of electrolytes will tell you how well certain chemicals are removed or not removed. And that is where you can conjecture that there could be toxicity or not. The other thing you look at is how well the kidney excretes urea. But this is not absolute because it also relates to the muscle bulk of the patient. Okay, so the key thing is to concentrate on what are the parameters that determine the excretory functions of the kidney and making sure that all the other parameters are fine. If the excretory function is fine, it will reflect in electrolyte homeostasis, a good homeostatic state for the electrolytes. And of course, all the other parameters are going to be okay. Toxicity is also related to protein binding. All right. The nature of protein binding will tell us how much of the free ions of lithium will be available or not available. But essentially, checking for renal function is key for you to tell, whether you are going to get toxicity or not. I hope I've answered your question.
Yes, please. Thank you.
Great. What other tests?
Thyroid function.
Why thyroid function? You are right. So thyroid function test.
Lithium can cause hypothyroidism.
That is true. But you haven't put the person on lithium yet. So one, at least I'll take that. Lithium can cause hypothyroidism. So you don't want the patient to already be in hypothyroid state before you put them on lithium. But why? What other reasons would you want to check for thyroid function? Yeah. Go ahead. I can tell you want to.
Rule out maybe other causes of the mood disorder.
Like?
Please, what about liver function tests, specifically albumin?
Liver function test is not critical. It's you can do it, but it is not one of the key workup. The two main workup are renal function, thyroid function, and of course your full blood count. Liver function can be done as a routine because lithium has nothing to do with your liver. So what other reason for
I
for
thought you just mentioned that toxicity is related to protein binding.
Yeah, I said depending on how much of it's not directly related,
Okay.
but then depending on it can also modulate how toxic you can become. But it's not a critical. I said as compared to renal function and thyroid function, you put liver function at the bottom. I'm not saying it's not important to do. You can do it, but that is not the first thing you look out for. You look out for renal function, which is key because that is the route by which it will eliminate. And then you look at thyroid function for some reasons. And one of it has been mentioned that lithium can cause hypothyroidism. So you don't want your patient to already be in hypothyroid before you put them on lithium, it will worsen it. And therefore, as a pharmacist, when patients come with prescription to the pharmacy for lithium salt, you must ascertain that they've gone through these workup and that they've been cleared as okay. And that this drug is being monitored under supervision of a specialized doctor. Otherwise, it will be dangerous to put the patient on lithium. But there is another thing. Have you heard of thyroid storm? Or thyrotoxicosis? What is thyrotoxicosis? Doctors, can you help us?
High levels of thyroid hormones.
Great. High levels of thyroid hormones. And what if the person has high levels of thyroid hormones? What can it cause?
I think this Francisca, the patient can exhibit certain characteristics of that could be anxiety, palpitation, tremor. That's also certain symptoms that patients with certain mood disorders or can also present.
In fact, one of the things, the differential diagnosis of mood disorders is hyperthyroid states, like thyrotoxicosis, because hyperthyroid states can cause mood disorders. So hyperthyroidism can lead to mood disorders, especially there are two major mood disorders, bipolar and mania. Thyroid storm does not cause depression. Hyperthyroid state does not cause depression. Hypothyroid states can cause the person to experience clinical depression or what we call major depressive disorder, as we explained yesterday. So hypothyroid states can lead to depression. So one of your differential diagnoses for persons suffering from depression is whether they have a thyroid problem, and you can really find out when you do the thyroid function test. Or in extreme cases, clinical examination will show that they have features of thyroid problems. Now, when you treat the thyroid function problems, the mood disorders would improve. Either the mania or the bipolar or the depression would improve. So those are the reasons why you do this. Now, when you do the workup and there is derangement, you make sure you correct the derangement before the physician. So the pharmacist must work with the physician to ensure that the parameters are normalized before the person goes on lithium. Who can tell me the therapeutic window of lithium?
0.5 to 1.5, what? 0.5 to 1 millimole per liter.
You're giving me the range. I'm saying the therapeutic
It has
window.
narrow therapeutic window.
Okay.
Yeah, it has a narrow therapeutic window. That is true. But how narrow? Is it more than one, less than one? Okay. Is somebody in the smoke in the first row?
Yes, sir.
Allergy. That is allergy.
Allergy. Allergy.
Yes, sir.
I'm giving you a clue. Is it more than one or less than one, the therapeutic window?
Less than one.
Less than one. Specifically, which figure?
I'm lost, Ellie.
Okay, good. To your immediate right, who is there?
Right.
Right. Yes.
No.
You don't have an answer?
I'm not very sure.
Okay, conjecture. Let's see if you could be right.
0.75.
Okay, to your immediate right, who is there?
Sandra.
Sandra, can you attempt?
1.
To your immediate right, who is there?
Francisca.
Is it Francisca, can you conjecture or do you know?
From what I've read, I think it's a range that they've quoted. So I'll put it at 1. They've quoted 1 to 1.5.
Okay, behind Francisca, who is sitting? Who is sitting behind Francisca? There's nobody behind Francisca.
I'm not
Oh,
sure.
the reception is not good at your end, so you are not hearing me.
I'm not sure about. I don't know if it's 0.5.
Well, you are close. You're so far the closest. I can see someone wants to make an attempt.
Is it 0.6?
0.6?
Yes, I knew it.
It's 0.6 millimole per liter. That is the therapeutic window difference between the lower limit and the upper limit, and it's usually traditionally quoted as 0.6 millimole per liter to 1.2 millimole per liter. Now, there's the one you are quoting, 1.5, are the different kinds of machine ranges that you can have depending on what machine you are. But in typical SI units, it is 0.6 to 1.2 millimole per liter. And the patient must be at all times in between the two. Now, if the patient's lithium levels goes below 0.6 millimole per liter, which is the lower limit, the person does not get therapeutic benefit of the drug. Now, if it goes above the 1.2 millimole or close to that, the upper limit, or above the upper limit, the patient can experience toxicity. And because the lithium has a very narrow therapeutic window, a small bump in dose can cause a very big upward adjustment in concentration or a lower adjustment in concentration. So it's important to take this, to note this, and it helps in your psychoeducation and your pharmacovigilance monitoring of the patient. Now, people on lithium, you don't just give lithium and go to sleep. That is why a specialist must be monitoring the patient. And for you monitor the patient at certain standardized intervals until they are stable, and then you can do once every quarter monitoring of blood screening of concentration, whilst you are monitoring the kidney and the thyroid functions at least twice a year when they are in the stability phase. Initially, you will monitor it quite frequently, but when they are very stable and everything seems okay, you will probably monitor the laboratory screening and investigations twice a year or once a year. But the lithium assay is monitored at least a quarter. So every quarter, the person screens for lithium concentration.
Hello,
I hope
Dr.
I've met.
Dene.
Yes, I'm here. Yes.
This is just an additional, or I want to find out whether the labs in the psychiatry hospitals, do they perform lithium, I mean the levels of the lithium in the patients?
Yeah, very
Because
good
once
question.
a while, I work at the lab, Ghana Standards Authority.
Yes, I send a lot of
yeah,
samples there.
so it's from you, eh? I want to know.
Yes, it's from me. And so Peter sends the results to
Yeah,
me by email
Peter
every
Kote
time.
Papafield, yes.
Yes, yes.
Okay.
So it's me. I send them over.
Okay.
No patient of mine goes on lithium without coming to Ghana Standards Authority to do without samples. And for those in Kumasi, I arranged with Peter such that they will send their samples. We get the nurses to package their samples and send by EMS or by courier to you.
Okay. Okay. Thank you. Now I know it's you.
Yeah. So.
So you see my signatures all the time.
Yes, I do.
I'm Janet Aidu. I'm the head of the lab.
Oh, okay.
Yeah.
Oh, great. I'm happy to be interacting with you. Yeah. So that is why I know so much about lithium, right? Yeah. So please, as pharmacists and as people who are going to be superintending, don't take lithium lightly. So lithium is used primarily as the gold standard, but without a strong laboratory backup, it is suicidal to be putting patient on lithium because it's like you'll be shooting blindly. Lithium is not a type that you just slap your thigh and say, oh, I think, okay, let's make it 1,000 milligrams twice a day. No. You can't do that. You can do that with carbamazepine, but you can't do that with lithium. You start at depending on the age range, the weight and so on of the patient, you would start at a recommended dose for that patient. And the moment you start at that recommended dose, and that is after you've done the workup and the patient is clean and okay, you would start at the recommended dose. And within 72 hours, and usually I do within 48 to 72 hours, you will take sample for screening. Now, if you take the sample for screening and it comes that the patient is below the lower limit of normal, you would bump up or you would titrate the dose up, and within the same time frame, you check again. You keep doing that until you find the patient is within the normal range. Okay, if the patient is within normal range. Now, if patient is within normal range, you would continue, you would wait maybe a week to two and do a screening again. Yeah, once it stays there, then you lengthen the time, maybe to a month and a half, and do another screening. If it stays there or it's within the range, then you can say the patient has stabilized, and then you would be monitoring the patient every quarter. So every quarter, the patient does lithium assay screening. So Janet and her team would be very busy if there are a number of patients on lithium. Now, lithium is also used in treating acute manic states. But at the same time, you also have to have laboratory support. Okay, and it takes about 72 hours if the serum concentration is adequate within the therapeutic window to bring down the patient who is acutely manic to a state where they are calm. But generally, we use it in bipolar, and because of the lack of immediate laboratory support, it is not a drug of choice when you have to manage a restless, aggressive patient. Any questions on lithium before we go on to the others? Okay, so I take it that you're perfect with lithium. Now, the other most stabilizing group are the anti-epileptics, which also require monitoring, but their therapeutic window is so wide that you can use clinical judgment. The doctor or the specialist use clinical judgment to make a decision on dosing, and they also require monitoring. So, Janet, we can tell please, you and your team consider the monitoring of all anti-epileptics which are being used as mood stabilizers. The commonest is carbamazepine. Topiramate, and the rest, you know them. So I wouldn't belabor the point. So when it comes to bipolar, there is lithium as a gold standard, and then also anti-epileptic drugs. Now you use antidepressants only in depression. You use antidepressants only in depression or when the person has depressive features. So that's when you use the SSRIs as first line, or followed by the SNRIs if you need to continue, or the TCAs. Now, the TCAs are mostly the ones that are easily available, and therefore you can start with that one. But you put the patient on antidepressant only when you are 100%, or let's not, I wouldn't say 100%, but only when you are certain that your diagnosis is unipolar depression or a major depressive disorder, or when you have excluded the likely possibility of bipolar. You know why? Who can give me a reason why you must be sure that the person does not have a bipolar before you put the person on antidepressant? Or that the person must have only depression and nothing else?
Charles is going to answer that. Charles has the answer.
Charles, yes. Charles, I'm here.
I'm here. Yeah, it can aggravate the manic situation.
Oh, the person doesn't have mania. Yeah.
It can lead to.
The person has. It can lead to. That's a good answer.
Yeah.
It means that the person can flip into mania from depression. The person can just flip. So sometimes in the past, some doctors have prescribed antidepressants to people they suspected of having bipolar, but where didn't have clinical evidence to make that diagnosis. So they put the person on only antidepressant, and the person flips to mania, then you know that a person has bipolar. Typicals are generally used, the antipsychotics. Mind you that they are generally antipsychotics. But because some of them, especially olanzapine, has mood stabilizing properties, it is being used as a mood stabilizer. Quetiapine has mood stabilizing properties, so it's being used as a mood stabilizer. Aripiprazole is the same thing. But why would you use it in, say, bipolar and manic state, but not in depression? Alaji, can you help us, please?
I would say it had some anti-manic properties because.
Great.
Yes.
Great. That's all that I want. It's anti-manic. Indeed, it is not only when it comes to the treatment of mania. You can use the typicals, as well as the atypicals. Especially the typicals can push the person down into low mood states. But the atypicals are better because they balance. They are able to balance out. Okay, because of their mood stabilizing properties. So at the same, this one is anti-manic, which means that it is pushing the mania down, the antipsychotics. This one is better than this one. Atypicals is better than typicals because the atypicals, aside from pushing the mania down, this mania down, it also has the property of balancing it. Typicals don't have, all they do is push it down. They don't have that balancing effect, which is what we call mood stabilizing. So that is why you can't use antipsychotics in the treatment of depression, because the person is already down there and you are further going to push them down and they will not benefit. There are adjunctive treatment. When we say adjunctive treatment, what do we mean? Alaji, can you help us with the meaning of adjunctive treatment?
I think there are agents that can be added to the main groups used in managing mania or depression.
Great, that's correct. At what times do you use, or will a doctor or a clinician use adjunctive treatment to augment their already effective treatment?
I don't know. Sometimes it may be possible the side effect of the drug you are using may tend to swing to maybe from depression to mania, and you may need to add some agent that may balance.
No, unfortunately, no.
Sometimes you may also need some addictive effects.
No, if one drug is doing the trick, why must I add adjunctive?
So is it about
Let's say, yeah.
Yeah, is that about the main one have a late onset? So sometimes you need adjunct to for you to get the immediate effect before.
No. Adjunctives cannot have immediate effect. In fact, they may even have delayed effect. The main one has immediate effect. Adjunctives are helpers. Your helper cannot be ahead of the main person. Now
Treatment
you add.
resistance. Treatment
Yeah, is that great?
resistance. Yes.
Yes, that's great.
Treatment
Okay.
resistance.
If it is treatment resistance, you change drug. You don't do adjunctive.
Difficult
So
to
if
treat.
I'm putting, if it's difficult to treat, you change to a new agent, a main agent. So if I'm using olanzapine and it's not working, I'll go to carbamazepine or I'll go to something else. I'll not use adjunctives.
Well, could it be to prevent relapse?
No. Adjunctives are helpers, so they augment. Yes,
help.
yes.
I don't know whether I have the right idea, but I was thinking.
You may well have.
Okay, I was thinking that, for instance, if the drug had a side effect like erectile dysfunction, you would put in a drug that would sort of boost libido or will help in the erectile dysfunction, so as part of the treatment.
Well, that's a good try. But the point is, what you are saying is you are using a certain, that is also a main, you're trying to mitigate side effects by using another drug. That is not adjunctive. Adjunctive is helping the main drug to achieve the main purpose. And the main purpose is to treat the mood disorder. So the therapeutic effect, you are enhancing the therapeutic, or you are, you are enhancing the therapeutic effect of the main drug. So for example, that the person has bipolar and has been put on sodium valproate. Now the sodium valproate is doing well, doing very well, but clinically there's a bit, and you've increased the main drug to a dose that is therapeutically okay, that you cannot go beyond it. You add an adjunct to help the main drug move up. For example, you've increased the dose to the highest allowable pharmacologically. Going beyond it would mean getting into toxic range, right? So adjunctive, there are two things you can do. So the person is on sodium valproate, has reached maximum dose or maximum allowable dose, maximum dose by pharmacologic guidelines, or maximum tolerable dose. Okay, so you have to know as a clinician that patients can reach their maximum either by what the book says, what we have found through research, that beyond maybe 2 grams a day, the person gets into toxic range. So you're not going to go beyond it. Or the person's clinical response to the drug has reached a certain maximum beyond which they start experiencing side effects, even though you haven't reached the maximum pharmacological dosing. It happens. Okay. So if the person is on, say, 1,000 gram of sodium valproate a day, and is doing well on, there's good clinical response, but the person is not fully recovered, and you wish to increase to 1.5 grams a day. Now you increase to 1.2 grams, and the person starts experiencing side effects of sodium valproate. What do? This drug was doing well up until I got to 1.2. So you look back and say, which was the last safe dose? And the last safe dose was 1 gram. So I will drop from 1.2 back to 1 gram. And the side effects go away because that is the last tolerable dose for the patient. This is how you make clinical decisions. So the patient, you go back, you are not going to stop sodium valproate because when I moved from 1 gram to 1.2, the patient started having side effects. No. You go back and find that at 1 gram, the patient wasn't having side effects. But when I moved to 1.2 grams, the patient started having side effects. So I will come back to 1.0 grams. And at that point, I need something else to help the sodium valproate. The sodium valproate is good, The patient is responding, but he or she hasn't responded to the fullest that is expected. But when I push the drug further, the person starts having side effects. So that is one of the two. One is whether when you have the drug is doing well, but you reach the maximum dose. Two is the drug is doing well, but you reach the maximum tolerable dose for the patient, and it varies from patient to patient. So one or two things that you do, you may want to add a second main drug starting from low. So for example, the patient is on sodium valproate. I may add, say, aripiprazole and start from a low dose. In this case, this is really not adjunctive. I'm adding a second drug. This is polypharmacy. This is proper polypharmacy. So this one and this one are going to work in the therapeutic interest of the patient. So that's number one. Two, I may not add a main drug, but I'll add an adjunctive or an adjunct medication. Now here, an adjunct medication may be, I will add a drug like tyrosine as a hormone. Now tyrosine has been known to help patients with bipolar and patients with depression. So when I add tyrosine on its own, when given to people with mood disorder, would have very moderate impact on treatment. But when given in combination with a struggling sodium valproate, the sodium valproate now works very well without giving the person either beyond the maximum tolerable dose or the maximum pharmacological dose. So this is how so the adjunctive, so tyrosine is an adjunct. Now, aripiprazole in some situations may be adjunct depending on the condition that you are treating, but in this case, it is not adjunct. Sodium valproate has reached its peak, and I'm adding another one to take off from that peak to the next level. But here, tyrosine is kind of pushing the impact of sodium valproate to the maximum, and that is why it is adjunctive. I hope I've made myself clear.
Yes, you have.
I have a question.
Please do.
This is Justice.
Yeah, Justice.
You're saying the adjunctive therapy is kind of supportive. So why do you say it's not additive? If at the end of the day, you get a better therapeutic effect.
In the true sense of the word additive, it is adding. But then the adjunctive treatment on its own, the adjunctive agent, on its own is not going to achieve anything. But if I take sodium valproate out, aripiprazole on its own can treat bipolar. Aripiprazole on its own can treat mania. So that is why it's not adjunctive. Tyrosine is an adjunctive because on its own it cannot perform.
Okay.
So that's it. But it has to be contextual. So depending on certain situations, aripiprazole in bipolar might not be adjunctive, but in some other condition might be adjunctive.
Okay.
Okay, so can we equate it to a drug like co-amoxiclav, where the amoxicillin is the main antibiotics, but the clavulanic acid is just there to support, or is in different contexts to that?
But I think when it comes to the co-amoxiclav situation, I think it's akin to adjunctive therapy. but not so quiet as adjunctive therapy because the clavulanic acid itself has specific activity on the bacteria. And they tend to be, I may be wrong, but if Dr. Bucci and Dr. Boabin are there, they can contribute and have nearly equal contribution to
the
killing the
clavulanic
bacteria.
acid doesn't have any significant activity because it's
Great,
just
then that is
inhibiting
adjunctive.
the beta lactamase, so that alone doesn't do much.
Doesn't.
So I think
then that is adjunctive.
Yeah, so it's a very good case of adjunctive.
Good.
Yeah.
Good. Right. Thank you. Right. So that's true. So you are right. Okay. So these are some of the adjunctive treatments that you can give. Tyrosine is one. Carbimazole is one. And in depression, carbamazepine can be an adjunct. Mind you, carbamazepine is not an antidepressant. That is why it's an adjunct in depression. I hope you are getting it.
Hello, Doc. Kindly come again.
Yeah, I said in depression, an adjunct medication can be like, an example is carbamazepine. So you use you can, for example, if the patient is on sertraline and is doing well, but you've reached carbamazepine to it as an adjunct, because carbamazepine on its own is not an antidepressant. So it will come and help the sertraline. I hope you are getting that point.
Yes, sir.
Now that you are understanding the difference between adjunctive medication and a second non-adjunctive medication. Yeah. Okay, good. So that's how you treat. So for how long would you treat bipolar? Who can give me an answer? Yesterday we learned that the enduring severe mental psychotic disorders you treat for life, like schizophrenia, schizoaffective delusional disorder, and schizotypal personality disorder.
Hello,
you don't
Doc.
treat.
Before you continue, can I ask a question?
Please go
I'm
ahead.
Ponson Kudia. When you introduce this tyrosine, does it bring any synergistic effect or what? Because I don't
Tyrosine.
see. Yes. When
Tyrosine has been found to be, it's additive. All adjunctive treatments are additive, but on their own, they cannot treat the condition satisfactorily or into any significant measure. That is why they are called adjunctive. Like I gave an example, the patient is being treated for depression, and you put the person on sertraline, which is an SSRI. Patient is doing well, but now has reached a dose limit that beyond which they get side effects. So are you going to change sertraline to another drug? No.
So when
sertraline
you introduce,
well.
in this case, when you introduce the tyrosine, what role does it play?
Tyrosine is additive. Tyrosine augments or is able to multiply the effect, let me put it that way in quotes, the effect of the main drug without necessarily pushing the main drug into toxic range for the patient.
Okay. Thanks.
Okay.
Is that clear?
So
That's clear. All right, because when I was coming, I had a case of clavulanic acid. You know,
exactly.
Yeah. So I think it's the same phenomenon.
The same phenomenon, yeah. The same thing. So where were we? Where were we? Anybody can remind me?
How long do you treat bipolar?
Yes, so bipolar. Treatment duration. If you get it correct, I have lunch with you the next time I'm in town.
I think you take it for at least 2 years. 2 years. And you monitor.
Okay, but it's wrong in the first place.
We have to manage it.
Dr. Dune, that's my very good friend. You cannot just tell him he's wrong.
Friend or not wrong is wrong.
Oh, then I'm sorry. Maybe it's not acceptable now. Okay. Well, bipolar. The moment you make a diagnosis of bipolar, it's a chronic condition. So the person manages this for life, so lifelong. So treatment becomes lifelong as well. However, under specific conditions, the specialist can, after a couple of years, not 2 years, can usually more than that, the person is stable for several years, maybe 3 to 5 or more. The specialist can decide, okay, we would wean the patient off medication and monitor and see if they ever have episodes. If they don't have episodes, then anytime there's an episode, we treat again until the person is 3 to 5 years stable without any episodes.
I think
but in the true sense of the word treatment for bipolar, it is chronic, and the person is on preventive treatment for the rest of their lives.
Hello, Doc.
Yes, I'm here.
Can we also say it is patient dependent? Because just like hypertension, we say some people say it is for life, but we have patients who are no longer on antihypertensives.
Yes, but it doesn't mean the person's diagnosis have changed. The person still is hypertensive. There may be crisis along the line, but how many patients go off very insignificant numbers? Majority of them.
I wanted to speak to that. I mean, if the patient got off, the patient may not be hypertensive. It might be pregnancy induced or something,
Induced,
so,
yes.
secondary when that is taken care of,
Exactly. So there are very few genuinely hypertensive patients who, at some point, maybe because of age, I know that, sometimes when the patient is very kind of aging, like their 70s or 80s or even 90s, their medication needs are reduced because the blood pressure may be dropped in, unsafe to unsafe levels until they don't probably need much of the drug or very little or not at regular intervals to maintain their blood pressure. So that can happen, but it's kind of rare. So bipolar is for life prevention. Now, mania. Mania means that that's the first time it's happened. If the person just has got the first episode of mania. If the person has first episode of mania, you treat until symptoms resolve. So first mania, you treatment till symptoms resolve. And then you wean the patient off medication. And if you wean the patient off medication and nothing happens, the weaning period can be 2 to 4 weeks. Okay, you wean the patient gradually, you tail it off, and nothing happens. 6 months, nothing happens. You are monitoring. 1 year, nothing happens. 1.5 years, nothing happens. So thank God. Maybe the person has served their once in a lifetime entitlement. It never happens again. But then, when it happens again, second mania technically equates to bipolar. When you have mania more than once, we change the diagnosis to bipolar and treat you for life. I hope you are getting it.
Yes.
Good. So first episode of mania, and the clinician must be certain that this is absolutely true. According to evidence, the person, this is the first time ever in their lifetime they have. If it takes 2 weeks for the symptoms to go away, that is it. You take the person off medication and say, go and sin no more. If it happens, we will treat. But if it doesn't, you are safe. It's gone. But if it happens a second time, technically the person is considered to be having bipolar. The reason why this is so is that if you follow such patients who have recurrent mania over a period of about 25 years, they will have at least one episode of depression. And we said that bipolar means a person swings between mania and depression. So if the person within a period of time would definitely have a depression, we are not going to wait for the person to develop depression before we say it is bipolar. We know that it would happen, or it's more likely in the 90-something percentage range happen that way. So we would save the person the ordeal of going through, because the longer you wait, the more difficult it is to treat. So once you have second episode of mania, you are technically, it is just like when you have a 0.47 and we say do it to one decimal place, you say 0.5. I hope you are getting it. I'm just using this as a crude way of explaining. Forgive me if it didn't meet your destiny. So we are not going to wait for the person to develop a depression in the long term, which we cannot anticipate when. But we know that the person definitely at some point will develop depression. So we make the diagnosis bipolar and treat them. It saves them a lot of suffering in life and so on. And then also saves them the possibility of having treatment-resistant conditions. Yeah. Any questions? Then I latch on to depression and we are done.
Yes, two questions. Okay, so please go ahead.
Okay, Justice again. My challenge is why, after a second episode of mania, we put the patient on live treatment instead of going for maybe episodic or treatment impulses. That is, you treat when they have the challenge.
That's what I'm saying, that we know that in the longer term, the person would develop at least one episode of depression. And the moment the person develops an episode of depression, then it means the person swings from mania to depression, like that. So that satisfies the definition of bipolar. But we are not going to wait for that to happen. We are going to consider that the person already has bipolar. Otherwise, he will not have a second episode at all.
Martha would ask you a question now.
In the past, we used to call it recurrent mania. Recurrent mania. But with more research into this area and understanding, we say that this recurrent mania is not just mania alone. The person develops depression at a point, and therefore the diagnosis changes to bipolar.
Very clear. Question from Martha.
My name is Martha Jansalutrot. Please, I want to find out what happens when bipolars relapse, and what can a pharmacist do, or what can to support such a system and such.
Yesterday, I talked about the role of community pharmacists in medication compliance or therapeutic compliance, which is actually very important. Now, if the somebody with bipolar relapses, the first thing is to ascertain, is to get this patient to be reevaluated and for diagnosis to be ascertained again. Don't assume that because the person has had bipolar diagnosis, whatever you consider as relapse is bipolar again. It could be something else. Now, so you need to ascertain diagnosis and put the patient back on their last medication that they were well on. That is your reference point always. So if the person did very well on carbamazepine in the past, you put the person back on carbamazepine and titrate carbamazepine to allowable clinical effectiveness. And if it doesn't work, you may switch. If it doesn't work, then you switch. Or if it works to a certain extent, but not fully, then you can either add a second agent or you add an adjunctive agent. And then you monitor. So that's one of them. So the pharmacist can help the patient to be reevaluated, getting the diagnosis sorted out, and then you help them to maintain on the treatment. Now you are also going to ensure that you monitor their compliance to medication. And one of the ways is to help through collaboration with the doctor, institute laboratory monitoring of serum concentrations of the drug that they are on. That's the only way to tell that they are taking their medication. Or you put in place other measures. For example, that they put their drugs in the I don't know how you call that thing, where you can put your dosages marked into days. So Monday the dose is there morning and evening. Tuesday the dose is there morning and evening, or depending on how frequent they are supposed to take. So they are there, and the person now picks or keeps a medication diary, or you would have to call as a community pharmacist. You have a way of following up on your patients to remind them to take their medications and so on.
Please
so
follow
this is
up.
what you can do.
A follow up, please.
Go ahead.
Please, Ghana's Mental Health Act allows for community.
Your mic is off. Yes.
I'm saying that the Ghana's Mental Health Act allows for community management of is psychiatric cases allowed to be used here?
Yes, you can.
Okay. So I'm just wondering, with this explanation, whether our community pharmacists could, because we are not in that space from where I sit. We are not in that space. It's only trained mental health nurses or community.
So it's because you haven't put yourself in that space. So we need a lot of you to go into community mental health pharmacy therapeutics as pharmacists. When you self-specialize, I expect to see a number of you from this group self-specializing in mental health pharmacy.
I want to give you a privileged information, Dr. Dene. That question came from the chief pharmacist, so it's something that is there on her heart. And
yes.
I just want to inform you that you have had discussions with us to work with the college to train community pharmacists.
Exactly. And then you put yourself in their space. If you wait for them to call you, nobody would. You need to make yourself significant, that effort to get you in that space. So we need you. Now, currently, the nurses are doing the things that you are supposed to be doing. And therefore, we've given so much power and discretion to nurses in the community, which is affecting us now negatively because they are not doing the right thing. They don't know so much of the pharmacy aspects of the medications.
Okay, so
and
two more questions for you. Sharon first and then
Yes.
Divine.
My name is Sharon. Please, I'm back to lithium. I want to ask, what practical things would you tell the patient so that they know that, the lithium toxicity is occurring at home? What signs would you, the subtle signs that they should look out for?
First, in your pharmacoeducation through psychoeducation, you need to talk about the manifestations of toxic levels. So the patient knows when they begin to experience any of those manifestations, which we popularly call side effects. I typically don't use the term side effect because it's been so much abused. It has negative implications. The moment you say, oh, this drug has side effects, then people want to keep away. But I would say that manifestations of toxic levels, it gives the patient the fact it's positive. This one is a positive language. Okay. In the sense that I know that the drug is good, but when it goes beyond a certain level, it can give me problems.
Okay.
But the moment I say side effects, it makes the drug or the medication a monster, and it shouldn't be.
And
so,
also, sorry.
Yeah.
I wanted
So
to know, is
the
there any
first,
antidote to lithium
No,
toxicity?
lithium toxicity is there really no antidote per se. Is how do you get the lithium out of the system? And usually, if it depends, it's very, very, very toxic. It depends on severity. You may admit the patient and flush the system with fluids and the usual thing that doctors would do at the emergency room to make sure that the kidneys push out the excess quite quickly. Other than that, you manage it with dosage adjustments, and meaning that you need laboratory support on a day by day to make sure that the concentrations are coming down. And the moment the concentration gets to safe levels, the side effects would disappear. So you need to know what are the side effects the toxic level manifestations of lithium or any of the other drugs. So it's not only for lithium, but for all the drugs. So that's the first thing you do. I mean, the first and most important thing that you do. Educate, educate, educate your patient. Now, it is important to always tell your patient the name of the drug they are taking, how much of it by strength that they are taking. Don't think, we always assume that our patients are illiterate and they will not understand scientific, what do you call it, explanations. That is why you are the most highly educated in this field. You need to find a way of simplifying it. Your ability to simplify it makes you a very good scientist. If you understand but cannot explain to a third party, then you don't know anything.
Okay, Divine.
Yeah, thank you. I'm Divine. You partly answered my question at the tail end of Matt's, when you were presenting on Matt's question about the level of prescribers that we have. From where I practice, there is no psychiatric, specialist psychiatric in any of the district hospitals, neither the regional hospital. Prescriptions that come, sometimes you look at them and then it's questionable. I was going to ask, how effective do you think these people who do the diagnosis for us at that level, that's a community psychiatrist, but I
the
think
nurses,
yes.
The level is low, and we have a problem. I just the program I am at in Melbourne is addressing some of these concerns in Ghana at the moment, and research that was carried out by one of our psychiatrists in Canada for a PhD clearly, states that they are not equipped to make diagnosis and treatment, and yet we've given them that power. Because nature abhors vacuum. You guys are not filling that space. So the nurses will take it on. We don't have many psychiatrists, and so there is a lot of work to be done. And of course, pharmacists are more, much in terms of numbers, more than psychiatrists. So if you come into that space with the additional specialization that you're going to have in mental health pharmacy, you can do a lot more and take off the burden. That's one thing I would say. Second is that the system, and that is where the chief pharmacist, I'll be very interested in engaging you because you can influence policy where you can force the hand of mental health authority to zone out the country, zone out the country. We have barely 20 psychiatrists. They are not up to 20 yet, but around 18 thereabout so far, with new additions coming in now every year with the help of our training center in Kumasi, and now also forcing Accra to do more. So every year we will have about 2 or 3 new young blood being added onto the fold. Now, if we zone out the country, we can put one psychiatrist in charge of a zone. And that psychiatrist's duty that at least every 2 to 3 months, that psychiatrist would do an evaluation and vetting of all um, the treatment protocol, provide treatment protocols, algorithms to those on the ground who would be under some kind of supervision from that particular psychiatrist who runs in-service trainings for them to sharpen their use of those algorithms. And once every quarter would do an audit, a clinical audit of these algorithms and say that and see whether they are within the margins of error or they are wide out of the margins of error, and put in remedial measures to, over time, we will be efficient. And by that time, as we are getting more and more efficient, more and more people would come into the fold. This is the only way. I suggested this, many years ago, a few years ago, but somehow the system was not ready to accept that. That's the only way we can maximize the we can utilize our few psychiatrists efficiently. And with you guys coming in, a lot of responsibilities will also be on you. We also need psychiatric social welfare. As we speak, there is nothing like psychiatric social or mental health social welfare. We need to train them to augment your efforts and those of the nurses with the psychiatrists who are zoned out to supervise, having an overarching responsibility within this context. And that is when you see those prescriptions that you put quadruple question marks on, you call the psychiatrist in charge of your zone. Now, they will insist that the prescriptions be accurately filled, so we know where it is coming from and who made those prescriptions. Now, if you are at the dispensing end, we will be able to collect data from your end. How many of such prescriptions are coming there? From where? Statistically, we can determine the problem zones and be able to tackle those problem zones. This is how we can overcome our challenges. We don't need thousands of people. We just need to operate in an efficient, coordinated, multidisciplinary way.
Excellent. Can you wind up on the depression? I'm told that you've not touched.
I'm going to wind up on depression, and then we can move on to anxiety disorders, and then we have
excellent.
So depression. How long do you treat depression? Now, just like I said, first episode mania, and you are sure that this is first episode, you treat until symptoms go away. And then you take the person, you wean the person off medication, and you say goodbye, but not just goodbye, you educate the person that there's a slim chance that it could reoccur. If it does, come back and we will put you on treatment. It is only at that point that you can now tell the person that I think we need to put you on treatment for a much longer term to prevent reoccurrence. Now, so in the same vein, first episode depression. We now, unlike mania, here you will treat specifically for 6 months. And if after 6 months the person is well, no recurrences, nothing to complain about, you wean the person off. And I've told you the typical average weaning off period is 2 to 4 weeks. Now, first episode, people with first episode depression might never have it again. About more than 50% of people adequately treated for this period. And emphasis on all of these things that is not only on depression, all of these that I've talked about is treating the right drug or choice of drug, right dosage, and accurate compliance to regime. If you are supposed to take it 12 hourly, you don't take it 24 hourly. If you are supposed to take it 12 hourly, you don't take it 15 hourly intervals. If you are supposed to take it 24 hourly, you make sure you take it 24 hourly. And the patient is followed up adequately. These are very important. It is only when you have achieved this clinically that you can say you've treated the patient adequately. For 6 months and there is nothing, you wean the patient off. And majority of them, more than 50%, would never have depression again in their life. So this should tell you that the fact that you've developed one psychiatric condition does not mean you are doomed. If we catch it very early and treat well, that is it. You will not have a problem. Second depression, that second episode depression, we say, research says, treat for 18 months. Treat for 18 months. And within this 18 months period, the person should have at least a period of 6 months where all the symptoms are gone. Complete resolution. When this is achieved, at the end of 18 months, wean off. And the percentage of people who will never have depression again is below 50%, about between 30 to 40% of them who have a second episode depression will never have a depression again in their life when they are adequately treated. Now, lastly, third episode depression. We say the depression has become chronic. So third or more episodes, so 3 or more episodes of depression, equal to 3 or more episodes of depression. We say the person is having chronic depression, and you treat this person now has a chronic condition. You treat for life, so it becomes lifelong. So it is in depression, you become a chronic patient only after the third episode or from the third episode onwards. Any questions?
Right, so any question? It looks like everybody is fine, Dr. Dune.
My question is...
sorry, Charles.
Yeah, I just want a clarification on the data that you shared yesterday. Did you say 10% of people with psychotic disorders are involved in crime, or 10% of crimes are committed by people with this disorder?
10% of violence is attributable to a psychiatric condition. Only 10%.
Okay.
I'm not necessarily psychotic disorders, but just any form of psychiatric illness, including bipolar, mania. It can be any of those. 10% is attributable. The remaining 90% is attributable to non-psychiatric conditions, including neurological conditions, medical conditions, other things.
Brichum?
Okay.
Yeah, my question is, Dr. Adone, how do we support people with chronic depression or bipolar who don't want to take the medicines, like after counseling and educating them on the lifelong treatments, they don't want to take the medicines, and especially those with comorbid conditions, like people with psychotic disorders and HIV. Most of the time, they are lost to follow up. They will come for medicines 1 or 2 occasions, and then you won't see them again. You call, you don't get them.
And that is where we come back to systems. If we have adequate community zoning and community teams, and I think the first lecture I said that the community team minimum should have a community mental health pharmacist or a mental health pharmacist, whether community or not, but a community mental health pharmacist should have a community psychiatric nurse, should have a clinical psychologist, should have a mental health social worker. Now, these are barest minimum. In a complete team, you should have a psychiatrist who does community care. So 5. See, 5 multidisciplinary people in it. That's team. Now, if we are able to do that, on the other side, you can have what we call community mental health officers who are case detectors and follow and are able to hint the team about any changes in those patients that within the zone. So you are not going to lose patients to follow up. In places like here and elsewhere, patients are hardly lost to follow up. They know wherever everybody is. It all has to do with zoning and mapping. Okay, so it has the answer to your question is not a solely clinical solution. In fact, clinical solution is the easiest part. What is the key solution is administrative policy and system management.
Charles?
I wonder, maybe he might have said it, but I wanted to find out with the manic situation, you can develop into bipolar. But in depression, it seemed to me from the treatment that you don't expect to have bipolar situation. I just lost
on depression. When we are talking about depression, we're talking about unipolar depression. Okay, in depression, once the person has depression, it means once the person has any characteristic of mania, it's no longer depression, it's bipolar. So if the person has depression, it's depression, and that is why you must be certain to rule out the presence of mania at any point in time. You must be certain to rule out bipolar. Once there is mania in the context of depression, that is a bipolar, and the person is not only having a depression. So the person with bipolar having features of depression, we refer to the person as having bipolar disorder with depressive features or bipolar depression. And that person is not treated like anybody with, what do you call it?
How can you rule out manic situation if the person presented first with depression has not gone into the manic state
That is part of the clinical skills of those who are trained to do that. Okay. And of course, you as pharmacist, I wish I could do that, but that takes, if you want to add another 2 or 3 years to your family, we can do that.
Thank you. Okay, so last question, and then...
Yeah, so yeah, I mean, let me just be pragmatic. There is a way through history taking and collateral information, evaluating the patient's life journey from as early as possible and as far back into their past as possible, using proven, scientifically tested methods in clinical methods to be able to detect whether they have had a manic episode in their past or in the current episode that they are having. And if you don't come up with any of those, it is like doing literature search in databases. And what you are searching, you didn't find, but you used all the scientifically proven methods of searching for the literature and you didn't find that topic. And that topic is not in this world. That is how you come to that conclusion. Yeah.
So we'll take two more questions, Dr. Dene. I've seen some two hands. So two more, and then we'll allow you to conclude on that, and you can move on to the next. So, yes, Alaji.
I don't know. It seems my question is partly answered. Talking about, aside using clinical features to make diagnosis for depression, talking about using all available scientific methods. I don't know practically whether it is available in having objective means of diagnosing, say, depression. My second question is about patients who had experienced a second episode of depression, treated, weaned off, and then after, say, 5 years, he has developed another one. Should we directly consider the patient as a chronic case and then treat him chronically? Or we should treat the patient, wean him off for some time, and then
well, it doesn't matter the length of the interval. If it is number 2 in the row, the person must be treated according to the protocol that I gave you.
Yeah, I think you were very clear on that. You know, he gave a very systematic protocol.
Yes, it doesn't matter whether it is. I told you that there was yesterday. I told you that, was it yesterday? Yeah, I told you that this woman who had a first episode of mania at age 30, and then had the second episode of mania at age 80, a 50-year gap. At the time I saw her, and this age 30 episode didn't just come. They came in a manic state, but I had to evaluate using the what do you call it, the methods available, and I went as far back into her life from early childhood and came up onto her current age, and we found out that at age 30 she had an episode, and therefore at the time when I saw her at age 80, her diagnosis was bipolar. It doesn't matter that it has been 50 years since the first one. So this is what you need to do. What was your first thing again, please?
Objective means of assessing the patient.
The objective means of accessing a patient is through clinical methods, history taking, examination of your patient. That is the number one diagnostic tool for any clinician, any doctor. There is no machine, like I was trying to draw your minds to, that if I came to you and said I'm having headache, how do you ascertain that that headache is accurate or is true? The only way you can ascertain is to go through the rudiments of clinical methods and clinical examination in gathering information, analyzing the data, and then coming to a conclusion. The same way you carry out research. How do you carry out research? You collect data. What is data? Data is the information you gather. So the same way a meteorologist can determine that today at 6 p.m. it will start to rain, and it does rain. It's the same thing. They gather information from around. The same way we scientifically do and come to a conclusion that the patient has depression. In one or few instances, you may have it wrong because that is human nature. So medical errors exist, not because the science is flawed, but because there are individual differences in the way we are able to scale ourselves.
So we'll take the last one, Dennis, and then we'll allow Dr. Dunen to wind up.
We heard that after the treatment of the first episode, about more than 50% are resolved. But then the second episode, when they successfully treated for 18 months, and after 6 months of resolution.
Within the 18 months,
Yes.
at least the person should have 6 months period where everything is at
resolved.
least. Yes, they don't have problems.
And then the person
so
is
it can be
weaned
1
off.
year, it can be, yes, the person is.
So what's the success rate in terms of not having another episode?
That's why I said that it drops. See, the more episodes that you have, the less able are you to treat it effectively. So the more episodes you have, let me put it this way, the more episodes that you have, the more difficult it is at success. It's just like any other condition. The more episodes you are having, the longer the thing exists or persists, the harder it becomes at treatment. Okay. Now let me I don't hope to confuse you, but to put you on another level. Mood disorders. The severity of mood disorders is directly proportional to duration or to age of the patient. So the older you become, if you were diagnosed at a younger age, the older you become, the more severe episodes will. So if your first episode, you were, say, 18 years old, and at 22, you have a second episode, that second episode will be more severe than when you had it at 18. If you have a third episode at 30, that episode at 30 is going to be more severe than you had it at 22 and than you had it at 18. I hope you are getting me. So I usually will tell when I teach that severity of mood disorders is directly proportional to advancing age or to advancing to duration. So the longer the duration of your illness, the frequency, the longer you have the disease occurring with your increasing age, the more severe it is. So severity is directly proportional to increasing age. Now, frequency of occurrence tends to increase with increasing age. So if your first episode was 18 years old and your second episode was 22 years old, you will find out that the third, fourth, fifth, and so on will be occurring at shorter intervals, progressively shortening the periods in between the times of wellness. So if your second episode was 22, the first episode was 18, that's a 4-year period. Now you realize that now the interval is reducing to 3 years, 2 years, 1 year, months, weeks, and then it becomes, without the adequate and proper intervention, it now becomes a continuum, and then you will suffer some form of disability from it. So severity is directly proportional to increasing age. Frequency of occurrence is also directly proportional to increasing age. Now, response to treatment becomes inversely proportional to increasing frequency or increasing age. So so it means that, let me see if I can go back to sharing the blackboard. So it means that response to treatment that inversely proportional to increase in age, and also inversely proportional to frequency. So what that means is that if you don't get as you are advancing in age, you don't get episode, then the response is high. If age earlier onset, response is high. But as the age is increasing, response is reducing. So it becomes more difficult to treat. Mind you that severity is directly proportional to increasing age. So it means that severity would be inversely proportional to treatment response. Okay, I'm just putting this in mathematical form so that you probably be able to understand that if you don't treat, if at age 18 we didn't treat you adequately, by age 22, when you get another episode, the response to treatment will be decreased and severity will be high. Than your previous. So it's important that some of these information are taken note of in your discussions with your patients so that they know that treating it is very, very important. And it does happen when the person, and mood disorders does occur to, to patients at quite a younger age. And we have this myth that we don't give medications to children or to people in their teenage, that it is too much and so on. But that is false. Because when we deny them of treatment, then when in their adulthood, the condition comes or recurs and it is difficult to treat, it persists, you get deficits and you have disability. I hope I've made myself clear. Then we
Very
can
clear.
move on
Very clear.
Yeah. All right, so anxiety disorders. What? Anxiety is a function of the brain. Anxiety is a function of the brain. And therefore, just like mood is a function of the brain. So we're going to look at, so you should be able to understand what anxiety and anxiety disorders are. Be able to differentiate fear from anxiety. They are not the same. And be able to differentiate between types of anxiety, which I will just touch on. Be able to formulate types, but that's not so much. But I think the first three and the last are my biggest part. So, who can tell me what fear is? What is fear?
Fear comes about when there is a presence of a threat, which is real.
There can also be fear when it is not real.
That's anxiety.
No, that's not anxiety. If, for example, right now, somebody in the auditorium screams, "Snake, snake, snake," out of the blue, I'm sure a number of you would jump onto their decks or run out before you realize that it was just joking or something like that. So it doesn't have to be real. It can be perceived. And there will be fear. All right. I mean, there's still people who cannot sleep in the dark because they perceive that something will catch them. I don't know what that thing is anyway. Now, anxiety denotes your emotion. Anxiety, the function of anxiety modulates our emotions. So anxiety means emotional or emotions. And the emotional function, anxiety function is emotional function. So when you say anxiety disorders, what we are saying are emotional disorders. Mind you, mood disorders are not emotional disorders because mood is not emotion. Mood is mood. Mood has to do with your energy level, your psychic energy, the way you feel energetic or not energetic. Anxiety determines your emotions. The difficulty with the mix up with mood is that both anxiety and mood they're like bedfellows. It's like diabetes and hypertension. Most of the times when somebody has hypertension, just give the person a period of time, they develop diabetes or vice versa. But it doesn't mean that when somebody has the hypertension, they necessarily must develop diabetes. No, you can have only hypertension for the rest of your life. But many people along the line will develop the other. So they are like bedfellows because the pathophysiological pathways to their development are shared. The same neurotransmitters in different proportions will cause anxiety problems. In another proportion will cause mood disorders. So that's why they tend to be. Yeah. So you the emotion or anxiety, emotion has what we call fundamental units or basic unit, and one of the emotions, the emotional basic unit is fear. Now, another unit like or fundamental unit of emotion is joy, hatred, anger, shame, guilt. All of these are emotional units. All right. So fear is just one of the many emotional units. Just like you have joy, just like you have guilt, shame, and the rest. You can Google and see a lot of functions of the brain that fall under these fundamental blocks of anxiety or emotion. Now, and we say fear is an alarm response to present or imminent danger, which is real or perceived. Present, as in real, it is there, or imminent, it hasn't happened, but we are assuming that it is happening now, or it's happening now. So it's perceived. So that emotional unit called fear is not anxiety. Anxiety is the bigger umbrella where it's a blend of all the emotional units. So joy, anger, shame, guilt, all of it are together within the context of the function of anxiety. Unfortunately, when the function of anxiety becomes problematic, the most affected emotional unit within that complex is fear. So fear gets a bashing. It's more affected. It's the one that is predominates. Let me put it in. It predominates. It predominates when the function of anxiety becomes deranged. Just like depression dominates when the function of mood gets deranged. Just like hypertension dominates when the function of blood pressure management becomes deranged. So that is what happens. So anxiety is a blend of a number of discrete emotions, including fear. So we say that anxiety disorders means emotional disorders. So anxiety is the same as saying emotion, the function. So the anxiety function is emotional function. And we all need good emotional function to stay healthy. Okay. Now, so what is the meaning of anxiety? Not anxiety disorder. So anxiety. Anxiety is said to be the future-oriented state in which you are. Is a future-oriented state associated with preparing for possible upcoming negative events. So, for example, you could have decided to stay at home or be at your office without coming to class, but you made provisions to be in class yesterday and today for these lectures because you know that there will be negative consequences if you don't. You enrolled into this program out of your own free will, but there is consequences attached to not abiding by the tenets of the program, and therefore it is anxiety that made you to take time off your job. Some of you have come from far and near, and you could have done, as we say it, better things with your time, but you are sitting here. It is anxiety that made you to come. It is not because you fear me or you fear Dr. Boabin. No. Okay. It is anxiety to prevent negative outcomes. You don't want to, a lot of you, this FAMD program means variously to you. For you, some it means prestige. For some, it means more money in your pocket because you get promoted. And therefore, if you don't get your FAMD done, then it means something: humiliation, loss of status, and a whole lot of things that mean a lot to you, that defines who you are. And that is what we call anxiety. Anxiety is that function of the brain that makes you make provisions for your children, and in a way to keep them healthy, to keep them from harm, to make sure that they get to school without getting knocked by a car or being kidnapped by somebody. So you put in a lot of effort to make sure that their safety is assured. It's not because they are definitely going to have a problem. No, it is anxiety that makes you do that. Just 1 second, let me put off this alarm. Thank you. Thank you very much. So it is anxiety that makes you do all of those things. It's not because you can afford them. That is why you do that. You don't even think about the money or the resources you are expending. You are thinking about to prevent negative outcome. You are preventing negative outcome. That is why you go about doing all the things that you do for your family, your children, your spouses, your partners, and so on and so forth. The same thing with your office or the job that you are doing. It's anxiety that makes you put certain things in place to prevent negative outcome, or all the things you do to prevent negative outcome or catastrophe, or that part of the brain gets diseased. Then you are not able to function normally, and mostly it is the emotional block of fear that gets most affected. This one that gets most affected. And therefore, people with anxiety disorders tend to have an exaggerated sense of fear. An exaggerated sense of fear. And that is why some people erroneously interchange anxiety with fear. No, it's not. Or anxiety disorders with fear. It's not. Any questions so far, so that we can move on? If you don't understand this bit, you will not be able to comprehend the rest of it.
You actually reinforced a lot of things that Abochi talked about earlier on. There are a few questions around. Nicodemus.
Yes, Doc, a little clarification for the definition. You said anxiety is a blend of emotional limits. And
emotional elements, yeah.
Yes, and you also said, you gave us some examples of emotional limits. You said fear, guilt, shame, joy, are all examples of emotional limit. But emotional limit. But
No, elements. The
elements.
discrete units, they're building blocks.
Oh,
They are
okay.
the blocks, they're units.
Oh, okay. But going further, you were stressing on the negative outcome. So I was a bit confused when
Anxiety always prevents negative outcome. So that nothing bad would happen. You put in place, for example, it is anxiety that makes you when you build your nice houses, you put all those burglar proofs and made all those alarm systems and make sure that you put a private security person there. Otherwise, you won't do it. It is anxiety. It's not that somebody is coming today or tomorrow, but you are preventing that from happening. You are preventing the catastrophe of an armed robbery, of somebody breaking through. And not only that, they were picking your things, the kind of things that can happen in terms of physical injury, death, and even death. You are trying to prevent. That is a future-oriented state. That is what the definition, the future-oriented state, the things you are doing now to prevent a negative outcome in the future. In the future can be minutes, seconds away, or minutes or days or years away. So that is the function of anxiety. Without anxiety, we will not provide for our family. Without anxiety, we will not take certain steps. Without anxiety, you will not put in measures to prevent embezzlement and thievery and the rest in your pharmaceutical outlets or your offices and so on and so forth. So it always targets preventing catastrophe or negative outcome.
Okay. So in this case, why are we wasting our time learning anxiety? Because it is positive.
It is positive. But then when that function, like mood is positive. Mood gives us the energy to go around. But when there is a disease, because there's a part of the brain that controls that function, all right? When there's dysfunction, then you go into a state of mood disorder, and then you can fall under any of the categories of mood disorder. The same thing with anxiety. So when the function of anxiety becomes dysfunctional, then you develop an anxiety disorder.
Okay.
But we are saying that amongst the elements that come together to give you the function of anxiety, the one that is most affected, or the predominating factor that gets affected when that function goes wrong, is fear. And so you have people with anxiety disorders, all of them, no matter the type of anxiety, what predominates is an exaggerated sense of fear.
Yeah, I think I'm getting it. You said that if you don't get this, you can't continue. So I want to be sure.
Yeah. No, that's fine.
So
that's
I'm
fine
trying to
now.
get it. It means that what we are doing here is we are going to rather talk about the disorders that come in the process of anxiety. Being anxiety. Okay. Thank you very
The
much.
function of anxiety, but you need to understand the normal before you can understand the abnormal.
And in the morning, I asked a funny question, but I also think that it goes then, especially people in the religious environment will say that do not be anxious. So in this case, how do we blend that religious teachings with this concept? I just want to have the basis and then.
Well, when they say do not be anxious, is that do not think that there will be a negative outcome when you trust in the Lord. If the Lord is your yes.
I was saying Prisha Donne.
Yeah, so that is the meaning, what the Bible says, or what the biblical, do not think that there will be a negative outcome if your hope and your trust is in the Lord Almighty. That's what it means. Okay, so it doesn't mean that the function of anxiety will stop because you trust God. Otherwise, you will not make preparations for for example, for shelter, for food, for you know, work and vacation and those things. All of these are the anxiety function that makes you do them. But it doesn't mean that you don't trust in the Lord. So we have to be very realistic about this. So I will not go into the history of it and so on. But so anxiety disorders, and I must be specific here with it. Here we talk of an anxiety disorder. So here, an anxiety disorder is the apprehension or the fear that is cued off by a threat to some value the individual holds essential. It's very, very important. I told you that many of you, the Pharm program means something to you. It means something that defines your very existence. Otherwise, you will not pay monies to come and sit here. You will not leave. Some of you have flown from Accra to come and sit here. Some of you have driven from maybe a rural district that you are the only person that you've left everything and come to sit here to do a top-up program. It means something. The individual holds essential at this moment over and above any other thing. That is why you are there. Now, and it's essential to your existence or your personality or as a whole. Now, this threat may be to your physical life, like the threat of death, or to your psychological existence, or to anything that means loss of freedom, meaninglessness, and so on. Or the threat may be some other value which you identify with your existence. It could even be patriotism. It could be love of another person. Some of you are doing it because your husband or your wife wants you to do it. As for you, you didn't even need it. But what it means to your wife or your husband is why you are there. As simple as that. Somebody is there because it means success. If I add from D to the string of degrees that I have, and when I mention my name and they write all the degrees under it, then it gives me a sense of having succeeded, having arrived, and it defines your person. Now, people develop anxiety disorders when what they hold essential to them gets threatened, and it affects the function of anxiety. I want you to understand this fundamental thing. Otherwise, no matter the criteria we use to define anxiety, you will still have it wrong. So, for example, you entered the classroom this morning and Dr. Buchi says, everybody put your bags and your things away. We are writing your final exam to determine the outcome of your family. We'll see those who would collapse and those who would brace up to the challenge. Why would you collapse? Those who collapse, there are a few things that can happen why you would collapse, that they are not prepared. And because they hold this as most essential to them, and they don't want the humiliation of a failure, the brain goes into a shutdown mode, and then they collapse. Because if they are taken to the hospital and by the time they are revived, the exam is over, we wouldn't say that you failed. In fact, Dr. Bochi will not put an F before your name or after your name. You will be given a second chance. So that is better than writing and failing. So the brain is very strategic about this. So what a person holds valuable to themselves, which I say holds essential to their existence as a personality, differs. Some of it very ridiculous. I will give you a typical example of a patient I saw. This gentleman is now in Canada pursuing masters and then going on to do his PhD. Now I'll tell you something. Maybe you will say this guy, maybe there's something wrong with him. But then, let you judge. This guy finished Kumasi Poly at the time. And immediately he did one of the engineerings. He immediately got employed by this mining company. Fresh from school, very bright, was top of his class, was employed by this mining company. And he does fantastically well with this mining company. He starts being paid in thousands of dollars per month. Now, listen, this guy never had to touch his salary. In fact, he never set up his account because somebody was assigned to set up an account for him. He has never, for the period, many years he was with the company, he never went to the bank to withdraw because he never had a need for money. He never had ever bought fuel at a filling station because a car was given him. Somebody comes and takes the car to go and fill the petrol and come. Somebody takes it to go and do maintenance. His clothing are taken away to be washed and brought iron. He doesn't have to go to the what do you call it, the boutique to buy anything. Let me. I'm coming to something. He never had to go to the supermarket to buy anything. Everything is supplied. His clothing were taken care of. He tells, and the stories is that he's never had to do anything. He doesn't even know how to write a check because he's never written a check before. Now, the gold crisis started and they had to do downsizing. Now, he gets another job. He takes his lump sum of money and he says that was the first time he ever went to a bank to deposit something. The first time he ever had to withdraw money and give some to his mother. And then he had a girlfriend. He's never had to give anything to his girlfriend, his fiancée. Now they are married, they have a child. But he never had to personally give money to. It was the company takes care of all of those things. The fiancée's account is credited with some amount of money at certain times on his behalf. Now this guy leaves this job, gets another job with better salary than he used to have, with conditions of service that are better than he used to have on paper and in nominal terms. But this company requires that you pursue the things. They'll give you a car, but you have to service that and bring the receipt. We'll reimburse you. You have to go and buy the fuel yourself, drive and go and buy the fuel yourself. We'll bring the receipt, we'll reimburse you. You have to look for your own accommodation. We'll pay for the accommodation no matter how much it is. You will have to set up your own DSTV, whatever. We would give you the money. But nobody is going to do it for you. You have to do it yourself. Can you imagine what happened to this person? He went into anxiety frame because he's never been plunged into this. Do I get any comments? Because I'm the only one not laughing here because I'm not hearing you.
Well, I wish you were here.
We put it permanently on for some time. Whilst we listen to the story, we put it on. So you hear our emotions.
All right.
We want you to feel our emotions.
So this is a real true story from the chambers of Confanochi. No, can you imagine the way I felt when I was listening to this guy give me all these details? I almost at a point said, my friend, get out of my office.
But Dr. Done, don't you think it was natural for him to have the anxiety? Because he didn't have the skills and the experience to do that. And it was natural.
Exactly. It is, well, you are saying it is natural, but it is not natural to develop a disorder. It is natural to have anxiety as a function, heightened. But you and I, with competent functions of anxiety, will return to normalcy in no time because, after all, he is not losing anything essential. If it is the money, he's even getting bigger monies than he was wherever. He just needs to now adapt, or probably the company also gave him what do you call it, a leeway to hire anybody to assist him, and they'll pay. You understand? So he really didn't have, in terms of reality, there wasn't any reason for him to be afraid because he still had backup. But then, being plunged into the real world where he now has to do things for himself and he didn't have the skill, heightened, had a threat. There was a threat of some value to him that he was going to fail if what if he made the wrong choice? What if his fiancée now thinks that so and so, and this lady was going to leave him? He had all kinds of things going through his mind. In fact, when he was talking to me, the thing he said, Doctor, there is really no reason why I should feel afraid, but I'm afraid. I hope you're getting me. There is really no reason. Aha. He himself recognizes. Mind you, people with anxiety disorders, they have insight because the part of the brain that controls insight is not affected when you have problems with it, because the part of the brain controlling anxiety does not interfere with the part that makes you recognize what is happening to you. So he has insight. And lo and behold, when this anxiety problem went on, I said that like hypertension and diabetes are bedmates. The same is anxiety and depression. Over time, he developed depression and we had to treat that one alongside with anxiety. It was after our effective treatment that he was able to put his life together, come to a conclusion. He had so much money, and then he decided, look, I will have an HND. I need to get a master's, and I need to top up and get a master's and do something. And then he applied to schools, and now he's in Canada. And just recently, I think about a few months ago, he came back to Ghana. We communicate a lot. He came back to Ghana to pick his wife and daughter. They are back in Canada, and he's doing very well. He's winning awards and so on. So that's good. So just to let you know, I brought this story so that you don't think of things so far-fetched only as the reason why somebody can develop an anxiety disorder or why somebody can feel threatened to their person. But things that to you might mean nothing can mean something to another person. So like we say, one man's meat is another man's poison. Any questions up to now? So that if you understand what will lead to an anxiety disorder, then we can proceed.
Yeah, Dr. Donne, the story you just told, does it mean that our upbringing can have impact on us? Because naturally we are all brought up to be able to face life. But there are some people who, in quote, are so privileged that psychologically they are not prepared. Does it mean that these things have a tendency to affect us in this way, maybe when we are called upon to make decisions for ourselves?
Yeah, it's important. You don't necessarily need to have everything in life not to be prepared for real life. You can have a poor parent who is so overprotective of their child that they hardly will allow the child to encounter any specific difficulty apart from the usual difficulties that they cannot really overcome as a parent. But what is essential to the child's livability, they make sure that the child does not suffer those consequences. All right. Now, that child may come from a poor family, but may have coping problems later in life. And a person from a rich family will not have because they were allowed to be adventurous. So really, it's not about the extent of resources, but it is about how much protection and so on that you've had from your parents. So upbringing is one. The other thing I want to talk about upbringing is if your parents themselves are overly anxious or have mild to moderate or different severity levels of an anxiety disorder, the chances are that children born to such parents would also develop anxiety problems.
Yeah.
Okay, so question for
Yeah.
you. Question, Martha.
I just want to make a contribution that before you can go into the extremes of anxiety, I think emotional intelligence have.
Yeah, I'm losing you,
Yeah,
Martha.
the microphone, sir.
Mm.
I'm saying that before one can go into the extremes of anxiety, it is obvious we need to deal with the new guy on the block, what we call emotional intelligence. I think we were taken in the last semester. But it is good that if any of us could find those books to buy, it helps a lot because some of the issues you need to understand yourself and then you are able to deal with it. But if you can't understand yourself, it's difficult to understand other people. And that is why sometimes we seem to get on each other's nerves. Thank you very much.
Yeah, that's true to a large extent. So something about why someone is fretting might be so out of this world to you that you think the person is stupid. Why this thing? Just snap yourself out. I've had people who say, "Oh, you say you are suffering from depression. Well, man, pick up yourself and be a man. Be a man. Be strong." Uh, when you have a fever, you can't tell the person when somebody has a fever and you say, oh, it's just a fever. Be strong, be strong. I mean, get yourself. This fever will just go away. No, it needs treatment. So it's important. And sadly, a lot of us in the medical field,
Yes, that's true.
those of you sitting down, that's what you say because
we deal with facts.
we fail to understand
Yeah.
some of these things. Yeah, and that is why if these, I'll get these. What do you call it, slides to Dr. Abuchi so that you would have it. In most lectures where I've taught anxiety, I've taught it differently, and I've gone to the core for you to understand. Otherwise, you will just list the different types of anxiety and characteristics that define it without really understanding. We just do chew on for, and you won't understand. Okay. So, coming to understanding anxiety.
Dr. Jonah, I wanted to clarify something.
Yes.
So when you talked about the parents, is it that it's the environment or is it that it's genetic?
Most of these conditions have a high contribution from the genes. Of course, the environment either may dampen it or enhance it. Okay, so that child may not develop anxiety, but because of the environment that they are in, they develop anxiety. All right. Okay. Mind you that we also have an anxious personality type, which is not a disorder, which means that it is not preventing them from eventually coping with their situation. Unlike this gentleman who was perfectly all right, but because of an economic downturn, if the company had not had problems and he had not been retrenched, he wouldn't have developed an anxiety disorder. Or he may not have developed an anxiety disorder, let me put it that way. Okay, because ours is not an exact science, so the future can hold anything else. So, yeah, but the likelihood that he would have developed an anxiety disorder is very slim. So it was the leaving this job. But when he left the job, look, this guy did not stay at home for a second. By the time he was handed his package to his severance package. He had another job. He had another job that had already begun, serving his needs. So What was the issue? He never had a second where he didn't have a job. So these are some of the things I want to bring to the fore. So it has nothing to do with it. So with whether he had the resources or not. It's just about, it's here. It's all here. What do you hold essential to your personality? What do you hold? And if there's a threat to that, then you can have. And so in evaluating whether somebody has an anxiety disorder or not, you need to come to a clinical conclusion that the person feels a threat to their very existence. Okay. Now, I will give you a second example. I have this lady who is like a family friend and like a sister. It's like a big sister to me. One time she came to me and had, specific symptoms of a type of anxiety we will talk about later on. And how did that happen? She said that a few years back, she was bathing in the bathroom. She was in the bathroom, washing down. And when she turned to the window, there was this gentleman at the window who was staring down her naked body. And at that moment, fear gripped her as though the gentleman had raped her in reality. So since then, anytime she had to wash down, it was a problem. She would go into this frenzy as if somebody or some male figure was going to pounce on her while she's doing that. And I can tell you it has affected her. She's not been able to sustain a relationship, meaningful relationship. And she's approaching 50 as I speak with you. I think she should be in the early 50s and she's not married. Or she is not only that she is not married, she's not in any sustainable relationship and she's been completely single for as long as I have known her. And she gets into this frenzy when it comes, when she's about to go and bath or be in a situation. She cannot, say, go to the beach and wear a bikini or to a swimming pool whilst there are people there. She can't. But she's highly successful in whatever she's doing. But she has an anxiety disorder. So it tells you that she considers something essential and there had been a threat. Can we move on?
Yes.
Good.
Sure.
Now, in all of anxiety disorders, there are a few things that run through them. And they are all the same, irrespective of the type of anxiety. There is self-reported symptoms of extreme fear. Let me put extreme here. When you get the slide, try and put extreme, excessive, extreme or excessive fear. That has a future-oriented state. So they like this lady, she lives in constant fear of the next time she's going to bath and what will happen and what may happen. This gentleman lives in constant fear of the next step he has to take. Which other thing would I be requested to go and do that I don't have the skills to do? So they report symptoms, and the symptoms can be in any domain of body functions. Some of them, like this lady, she says that her heart will pound, she will feel dizzy, she will sweat, her mouth will go dry, and so on. And then she'll start to tremble as if that in reality, whichever gentleman is actually, with her in person. No. When she thinks about going to bath. And she says she feels raped. So even though the actual act of forceful sexual intercourse hasn't occurred, she feels that it has occurred, but it hasn't. Now, this person is not gone bonkers, as it is not psychotic. So there's no presence of psychosis. So the first thing is that all of them will report self-reported symptoms of anxiety and extreme fear or excessive fear. So there is fear, which is the deranged element within the anxiety spectrum. And there's a future-oriented apprehension. So that is why I said anxiety and fear. All of them report heightened anxiety and fear responding to cues that signal the threat. So if she has to deal with a male figure in a certain context that mimic even that experience, then it signals that threat. Cues that signal no threat. So the person, a cue that may, for example, if she is in the bathroom and hears footsteps behind the bath house or whatever, wherever she is, it immediately sends fear signal. And sometimes the signal has no threat at all, but it will generate something. Cues that formally signal the threat, it means that cues that used to, they all report heightened fear and anxiety. And context, the context associated with the threat. There is this banker I saw, she used to work with Stanbic Bank in Accra. They were robbed by these teenage guys wielding ammunition, and she was nearly raped in front of her husband and the children. Her own sons and daughters were far older than an elderly woman, far older than these boys who came in, to the extent that and it was in the evening, in the night actually, early evening. So whenever it is getting dark, those are the contexts associated with that threat. The moment it's 6 p.m. going in there and the atmosphere is getting dark, this woman goes into frenzy. So those are the contexts associated. If she sees a group, to the extent that as a manager in her office, if more than 2 or more guys are entering her office, she starts screaming, rapists, 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 get out of here. And these are customers of the bank coming into her office. Now she's resigned from there. She's fine now, but she's found another passion and she's resigned from the bank. Okay? So these are some of the things that happen. So there are contextual threats. So very, very important. All of them do report any of these, either responding to cues that signal the threat, the real threat, or the perceived threat, or that has no threat, or signaled formally the threat, or are in the context associated with that threat. So it's very important. Now, thirdly, all of them report elevated stress reactivity to stimuli that may mimic or resemble what they have experienced. All of them have attentional biases to stimuli that may remind them of that. So what I mean by attentional biases is that they are overly conscious of things they may misinterpret to mean that. So if the thing just even smells or looks like it, but it's not it, their attention to that detail is very heightened. And their threat-based appraisals of even stimuli that are not very specific. Of course, your amygdala is the part of the brain that controls fear and anxiety.
Dr.
In fact, it controls anxiety, yes.
How related is the woman's case you just narrated to PTSD?
PTSD is an anxiety disorder. That's why I'm taking my time to go through for you to understand before we start talking about the different types of anxiety. PTSD is a type of anxiety disorder. I hope you are getting me. So that answers your question, right?
Thank you.
Great. So PTSD is a type of anxiety disorder. And all people, irrespective of whether it's PTSD or whatever type of anxiety, would have these features running through them, and you need to know about them. Now, you also have one of the features to come to a diagnosis of anxiety is that the person knows that it is senseless. It is not happening real, but they have a sense of helplessness. They can't help it. They are in a state of helplessness. Like this, my patient friend now in Canada. He says, "Well, there's no reason why I should be in this state. I don't just know, but I just get into it. I think it's happening." Because there's a perceived inability to predict. They don't have control or obtain desired results or outcomes in certain upcoming situations or contexts that mimic what is threatening to their situation. So, for example, those of you who are afraid of exams because of what it means to you, if Dr. Abuchi enters the class and has a bag full of certain papers and comes to put them in front of the class, even without saying a thing, that person's heart will jump because he says, "Hey, these are exam papers." These are exam papers when, in fact, there may be some handouts that he's bringing to give to the class. Now, so this negative state is accompanied by a shift in attention to what would be primarily a self-focus or a state of self-preoccupation in which evaluations of one's capabilities to deal with the threat is prominent. So that your capability or inadequate capabilities to deal with the threat is paramount. So that you find that the person feels unable to, and this is like, the first few points, that they are focused on that, they are preoccupied with it throughout the day. That's what happens to them. Now, this state now provokes a physiological response, and that is where the symptoms come in. So I told you about the lady, she feels dizzy. Dizziness is a physiological response. Okay, this dizziness is a physiological response. And sometimes they have bodily component response. So they may, she actually sometimes feels the hand of a guy on her skin, on her body, in an attempt to rape her. And there's none there. She feels that, and she gets into these goose pimples and so on. So somatic means bodily. So, and she feels, she trembles and feels faint. So all of these are stress response to the threat, and it is mediated by this corticotropin releasing factor, which leads to all the stress hormones like adrenaline and so on being released in response to the provocation from the brain. So you can read this for yourself if you don't. This by this gentleman called Spielberger, who, now tries to explain how anxiety goes through the way the brain will perceive it until it gives you the physiological response and therefore manifests in behavior. The behavior is that this lady would avoid having her back in places where there is a possibility that somebody could pass behind the bathroom, and she avoids swimming in going to the swimming pool or going to the beaches and all of that, and so on. So these are some of the things that happen, and these are some of the diagrammatic ways of knowing about how anxiety disorders occur. So There are a few other people tend to. I'm just putting together all that you have been, we've taught ourselves this evening. This gentleman called Lang also classified the symptoms into a system of 3 responses. That summarizes all that we have said. There is what is called the verbal subjective, where the person self-reports what is happening. Then overt motor activities, where they tend to avoid. So verbal subjective, they talk about what is going on in their minds, and then overt motor activity, where they tend to either avoid the situation, or we have to call somatovisceral activity, where physiology comes in and it leads to muscle tension and other bodily complaints. So people can actually report headaches, muscle tension, fatigue, and the rest associated with anxiety, because there's a physiological response. So all of these happen during the period that they are going through the anxiety response. So it's just a summary. So I talked about fear, just some further explanation. Now,
Dr.
what are some
Dole,
of the...
can I ask this question?
Yes, please go ahead.
The anxiety, could it also be a learned behavior? For instance, you're a soldier and they've told you never to sit with your back facing the opened entrance. You must always face the wall or something. Your back must always face the wall so that you can always see the entrance. And you find people that has been drummed into, I mean, they've been trained in that way. So the person would have anxiety if they ever went to a place where they are forced to sit with their back facing the entrance. So
yes,
I mean,
that alone will not provoke an anxiety disorder or extreme expression of anxiety. The core, Susan, it comes back here. The core is here. That's the core. That which they've been told, has it necessitated that with this soldier says that the moment I cannot face the entrance but with my back, then there's a threat to my life, to my existence, to the very core of my personality. Is there a threat of death? If the answer is yes, and the person holds that dear and valuable, then that would cause an anxiety problem for that what do you call it, soldier. I hope I've answered you.
in some way, yes. So it's a learned behavior. I mean, you can be trained into it.
It can happen influenced by the environment, but I wouldn't say it's a learned behavior. It's not. There are some of the soldiers who would sit, and in fact, majority of the soldiers, depending on the context, if the person is in their own home or in a friend's house and he's seated with a back, they don't care. But this person, to what extent do they hold that valuable to their very existence as a human being? If that means a threat, then yes, that person cannot be in a state where they would face or turn their back. So, for example, as a psychiatrist, I'm being trained that never walk ahead of your patient and never walk beside a violent patient. Always the patient must be ahead of you and at arm's length away. And over the years, I've imbibed that over and over. So even when you are on the medical block or on the obs and gynae block to help sort out a patient, or you are passing by or talking, and then there's a pregnant woman who you've turned your back to, you feel uneasy and you feel that this person could harm you. But within context, you say, oh, but where I am is not, this patient does not pose any threat and you are comfortable. But others cannot. They have to let the patient be irrespective of the fact that it's a pregnant woman. They would still have to be able to go through those steps. So it's in some way, it's what, to what extent do I hold that dear to my very existence and survival? If not, I can always restructure my thoughts and live harmoniously with whoever without feeling any extreme outbursts of anxiety. So yes, in some, the environment can influence, and you can say it's a learned thing, but it happens spontaneously most often than not. Okay, if there is no further question, we can look at these examples. So the verbal subjective and the anxiety, the person has thoughts of future threats. So now we are looking at the difference between just the element of fear and the entirety of anxiety, and differentiate it from depression as a mood. So you can go through that and see. Now, I just brought this slide to let you know that anxiety costs the economy. Anxiety disorder costs the economy a lot of dollars in terms of treatment, and also in terms of economic loss from the individual suffering it, because it does affect their productivity. And you found out that non-psychiatric medical treatment cost constitutes about 54%. We are looking at direct and indirect costs. Total direct psychiatric treatment costs about 31%. Pharmaceutical costs about 2%. So you are the least problematic here. Total workplace costs about 10%. And people with overtly severe anxiety can commit suicide, and that is why there's mortality cost of about 3%. So what are some of the causes of anxiety disorders? And they are broad: stressful or traumatic life events. So, and they are stressful or traumatic because of the explanation I gave earlier, that you hold as a threat to your very existence. Second is family history of anxiety disorders. That's genetic. So here is familial, or what we say genetic. So here is familial. That is when you can say it runs through families. Then childhood developmental issues, trauma, abuse, be it what, traumatic events also in childhood, like early loss of parents or significant other, not necessarily your biological parents, known patients who were being taken care of by an uncle or even an adopted person, and then the person maybe passes on, and they were left with no one to help them, and that experience have triggered an anxiety problem for them. People abusing alcohol, abusing prescription medications and illicit substances. Then the presence of psychiatric or medical conditions themselves can trigger anxiety. For example, people with certain types of brain tumors may be predisposed to the development of anxiety. Other psychiatric disorders like depression or mood disorders can predispose you to anxiety. Even some of the psychotic disorders can predispose you to an anxiety disorder. Any questions up to here? Because I'm moving on to something.
It's a general question. Does race have a modifying effect on anxiety and other mood?
It doesn't.
It doesn't.
No.
But there's a general feeling, or of course it may be anecdotal, that the black race are better able to deal with mood disorders.
So it's a myth. It's a myth.
Okay.
Thank you.
It's a myth. The prevalence of mood disorders within the African people of African descent is practically similar and same to elsewhere in the world, in fact, global. The only difference is the way it is reported. Okay, most people of Black or African descent would report their depressive symptoms differently from what a white or Caucasian would report. Normally, we report of the somatic situations rather than the mood components. Here, a white person can come to you and say, "Look, I feel so down. I feel so sad. I can't explain. I'm always crying." But the African will not come and tell you. They come and tell you about their headaches, their inability to sleep, how they wake up so early at dawn and cannot go back to sleep, and so on and so forth. That their appetite will tell you that they are not able to eat. They don't feel like eating and all of that until you probe the mood, the specific mood domains. If it is there, they tell you. So you find that eventually you get all that constitutes what the white or the Caucasian will tell you, but we don't tell it directly. So majority of people will not tell you directly. People with infectious diseases, general medical condition like cardiovascular, specific types of cardiovascular problems can cause anxiety. For example, people with DVT tend to experience some types of anxiety. People with valvular heart diseases tend to experience some anxiety. Malignant hypertension and even diabetes can provoke. Now, these are the types of anxiety. We have the phobias. We have panic disorder with or without agoraphobia. We have generalized anxiety disorder, obsessive compulsive disorder, acute stress disorder, or what they used to call, or what they still call, adjustment disorder. Adjustment disorder. So, or adjustment disorder, post-traumatic stress disorder. In fact, post-traumatic stress disorder and acute stress disorder are practically one and the same thing. The only difference between these two is the duration from the trauma. In acute stress reaction, it is immediate. Anytime immediate to the trauma to about a month. Post-traumatic stress disorder is any time after a month going to several years after the traumatic event. Then we call the same set of symptoms that constitute an acute stress disorder at one time as a post-traumatic stress disorder. Then we also have anxiety disorder secondary to general medical condition, like I've said. Any questions so far?
Yeah, please. I wanted to find out, can a kind of a treatment failure, for instance, trying to bring a BP down, can it be linked to an anxiety disorder?
A lot of people, about a quarter of people with high blood pressure not being controlled, especially, is because of an anxiety problem. Indeed, a lot of people with about a quarter of people with asthma or with hypertension or and so on are not having those conditions per se. They are only manifesting an anxiety disorder. One key culprit of that condition is panic disorder. Panic disorder is a type of anxiety where it can manifest in any of the organ systems. It can manifest in cardiovascular system, can manifest in the respiratory system, can manifest in the CNS, can manifest in the GIT. I had one patient who had recurrent episodes of diarrhea, and all that was because they were having a panic disorder, which was manifesting as GI symptoms. And he was on the medical ward being pumped with antibiotics. Nothing was changing because it wasn't an infectious diarrhea. It was just from panic disorder where they had squirts of diarrhea like 2 or 3 squares of diarrhea spontaneously and it stops. And you can actually draw a graph and the pattern, follow the pattern. That is what happens with panic disorder. So and people with respiratory features, sometimes it mimics, in fact, not sometimes, it always mimics asthma. A quarter of people diagnosed with asthma are actually having panic disorder and not asthma. Cardiovascular, it can lead to autonomic dysfunction, especially BP. And usually it leads to increase in BP. And a lot of people with increased BP, which are being treated with another quarter of them are due to panic disorder. So in panic disorder, the anxiety symptoms, occur in epileptic blocks. So it happens maybe for 3-4 minutes and stops. Then it can happen for an hour or 2 and stop. For the next 2 weeks, nothing will happen. And then it happens again for an hour or 2 and stop. So you can actually follow a certain pattern of the occurrences of the anxiety symptoms. In generalized anxiety symptoms, this continues. It's a continuous expression of anxiety, anxiety symptoms or anxiety features, where the person expresses anxiety over any situation. So the person expresses anxiety over what their children will wear, what their children will eat, how they are going to pay school fees, how they are going to go to work themselves. Hey, what is happening? It's global. They worry about everything, and it generates a set of anxiety symptoms. And some of those symptoms, which can be in any of these, would be sleeplessness or insomnia. And the difference between an anxiety, insomnia, and depression, I told that depression is that they are not able to sustain their sleep to the end. In anxiety, they are not able to initiate it. So the person would be in bed till thy kingdom come, and like we say it in Pina, you cannot sleep, or it takes a varied length of time for the person to be able to fall asleep. And then, so if you have initial insomnia, one of the things to think about is this person having an anxiety type disorder. Now, obsessive compulsive disorder is a type of anxiety disorder where the person views a particular thing as a threat to their existence. So, for example, that the person is preoccupied with getting infected, and therefore they are so preoccupied with cleanliness. When there's a little blood, if they don't get rid of that, until they get rid of that blood spot, they cannot rest. They feel their whole life will come under threat because there's a potential to infection, and they get into this all anxiety symptoms where they can get palpitation, they get dizziness. Until they are able to get rid of that thing, they don't feel comfortable, and they can have. So that's obsessive compulsive disorder. Some people are obsessed with getting things, properly arranged, or that even their desks in their office must be positioned in a particular way. Without it, they cannot focus, they can't do anything, they are paralyzed until that happens. That's what we call obsessive compulsive disorder. I've told you that acute stress disorder and post-traumatic stress disorder are one and the same thing. The only thing is the duration. And I said that acute stress disorder occurs immediately to the trauma that has occurred. And if it doesn't resolve after 31 months, then it progresses to what we call a post-traumatic stress disorder. So the example I gave about that my adopted big sister and the Stanbic manager I alluded to, they are having what is called post-traumatic stress disorder because it's more than the 3 months. But if she had reported to me exactly at the time that it happened, then that I would have made a diagnosis of acute stress disorder. So acute stress disorder is a temporary diagnosis. So if somebody cannot have an acute stress disorder for 2 years, after 1 month, if the symptoms don't disappear with adequate treatment and intervention and still persist, then the person migrates to what we call post-traumatic stress disorder, which is a more permanent diagnosis. Any questions?
I have a question. This is Justice. On the
Justice.
ASD to PSTD, is it 1 month continuous or 3 months or 1 to 3 months?
It's 1 month.
1 month. Okay, thank you.
Beyond 1 month, the person should be fine. Beyond 1 month, if the person is not fine, then we'll move to the realm of post-traumatic stress disorder. Now, post-traumatic stress disorder means the person tends to have flashbacks of the event, like in these cases. They tend to live as if it is happening, so they become over vigilant, looking out for the same situation, and then the flashbacks can be in dreams, it can be in memory, it can be in imagery, anything that brings it back. Then they become over vigilant, and then they relive the situation as though it is happening now. So with this woman, whenever it is getting dark, she re-experiences that attack by those little boys as though it was happening on the spot. It is happening now, real. It is not like they feel like it is about to happen. No, they experience it the same extent they experienced it when it actually happened. And they're experiencing it as if they're experiencing it as it is happening now. Not as if it is happening now. They are experiencing it as it is happening now. And that is why they get into those states. Any questions?
Good so far.
Right. So
Doc.
I would need you to read into detail.
Dr. Gordon.
Now, when you, before I respond to you, let me complete this. Sorry. I need you to read more around these types and anything else to make a lot more sense to you. Okay. Yes, sir. Now you can ask your question.
Doc, would you please consider jealousy as anxiety disorder?
No.
Jealousy is jealousy.
Jealousy, yeah, exactly. Jealousy is jealousy. It's not an anxiety disorder. Jealousy is a thought problem. It's a thinking problem. It's generated from your thought cells. It is not from your area of anxiety. Of course, the thought that brings jealousy can provoke some anxiety around those thoughts. But the jealousy itself is not an anxiety problem.
What about extreme jealousy?
Jealousy is jealousy, whether mild, moderate, or severe.
Doc, please, what about paranoia?
It's the same. It's a thought problem. It's a thought. It's a thinking problem. It's the way the thoughts are structured. So paranoia is thinking.
But how about the fear of losing a partner?
That can provoke. You said the fear of it's an anxiety.
There's a threat.
Once there's it's a threat. It's a threat to your existence if your life revolves around your partner.
So that one is anxiety.
It is. It's a fear. That's what you said. It's
depending on how you are managing it.
I'm thinking about.
So mind you that fear of losing a partner can lead to any of these types of anxiety in you. Yes. So at the end of the day, we are not going to say a fear of losing everything. Probably the diagnosis, the generalized anxiety disorder centered around losing a partner.
Doc,
Yes, sir.
This morning, I think I was pointing out some of the new anxiety disorders in the DSM-5. And I spoke about separation anxiety.
Yes,
and
yes, yes,
selective
yes,
mutism. I think
yeah.
maybe that is what is prompting that. But can you
Yeah.
comment on why OCD and PTSD have been thrown out of the anxiety classification at DSM-5? They've just created a whole chapter for them.
Because of the prominence it has, but it doesn't take away the fact that it's a type of anxiety. The thing about DSM-5 is it has a lot of controversies around it. I'm waiting to see the next couple of years what will become. People are writing all of sorts of things about it now, and we are still looking. We think that the DSM-4 was much better. Maybe some of us still hold the belief that the DSM-4 was much better.
Look, recently a friend of mine took to drinking and died. And we're told that...
Sorry about that.
We're told that he suffered what was termed midlife crisis. Is there anything like that medically?
No.
Midlife crisis?
No, there's nothing like that medically.
No, we're told that he felt that at age 50, he did not achieve anything in life. So he saw himself as a failure and started drinking. And, well, maybe to mute that feeling. And through the alcohol, he died.
It's possible that he developed he developed a generalized anxiety disorder, a panic disorder, and it was unbearable. Mind you that alcohol tends to, in minimal amounts, it has anti-anxiety effect, but in larger amounts, it aggravates. And by nature of alcohol, you develop tolerance and dependence when you are on it. So even though it will worsen the anxiety subsequently, the person is unable to stop. And of course, alcohol is one hell of a dangerous substance. It affects every organ system in the body, and it can lead to death, yes. So it's possible that I suspect he's probably developed panic disorder or generalized anxiety type disorder because of what he perceives as a failure, because that means a lot to him. He holds it dear as his survival and success, and that is not happening. A lot of those things happen, and we call it midlife crisis. It's just an English word describing a medical situation.
Dr. Dino, please, assuming someone for the past 10 years always has, say, a 2-hour bath, would you put it under the obsessive compulsive disorder? This person in another environment, I don't know whether it's about the warm water or what, but then in another environment is able to come out of the bathroom in very few minutes. But in the other normal environment where he lives, would always spend about 2 hours. Would you put such a person under the obsessive?
You see the point, the fact that there are varying degrees of it, from mild, moderate, severe. It can be aggravated by external factors, environment. All of these things that we've discussed has 10-20% factors that are environmental. So he can still have obsessive compulsive disorder and not express it in certain contexts. But generally in most of his existence, he would express it.
So are we going to move into management, Dr. Done, or you still have some?
So I'll move on to this just to buttress the point that the hallmark features for all type of anxieties are these three. First, there's irrational and excessive fear about whatever they deem as essential to their life. And there's apprehension and tense feelings about it. Then there's difficulty managing daily tasks or distress related to these tasks. So it impairs them. You understand? It does impair them. And I have a few things about acute stress disorder, some of the things that you can read about them, you otherwise would not finish. PTSD, I've explained a few things and given you practical examples to them, examples of the symptoms and how they manifest and so on. So you can look at that. Right. Treatment. Basically, it's still the same biopsychosocial. And we normally use the drugs we know as antidepressants. They are also the same that we use as anti-anxiety, especially the SSRIs and the SNRIs are popular in this case. But in treating anxiety, we use higher than usual doses for depression. So if we're using 20 milligrams or up to 40 milligrams of fluoxetine to treat depression, in anxiety, we'll use up to 60 or more milligrams to treat it. I hope you are getting me. And the psychological interventions, usually we said that it is what the person holds dear to their life. So we use cognitive behavioral therapy to help them deal with the negative thoughts. So, for example, this my friend in Canada. One of the key components of his treatment was psychotherapy when we instituted a cognitive behavior type therapy where we try to bring him down to reality and to restructure those defective ways of looking at his own life circumstances. That is what cognitive behavioral therapy does. Okay, and then the social interventions, the social aspect is practical guide to how he can become functional and live a normal life like any person. And then you keep monitoring their responses on a day-to-day, week by week, month by month period where they bring you feedback. They can have diaries where they write out the way they handle specific situations. You teach them how to keep diaries of that. And then when they bring maybe every 2 weeks, every week you are seeing them, they come with the diary with dates, times, and outcomes. You can design something out for them, and then when they bring it back, you would evaluate with them and point out areas where they were defective. And this happens within an environment of complete confidentiality, transparency, and non-judgment. So I told you that this man, when he was telling me his story, I almost said, "Get out of my office." But I couldn't have told him that. Otherwise, he would close up on me. Eventually, he found somebody who understood his situation and didn't trivialize it or made it look like he was out of this world. So I understand him. I understand that it is okay to be in that situation because it is possible. And then we went into him disclosing all the most outrageous things that occur. Then I found out what is inconsistent with the reality on the ground. And then we fashion out goal-specific ways of reversing it. Goals that not I am setting, but he is the one agreeing to and setting those goals because he wants to live a normal life. So this is how you go about the biopsychosocial treatment. We talked about comorbidities. The first comorbidity to anxiety disorders is depression. Like I said, they are like bedmates. There are other comorbidities. For example, people with schizophrenia tend to have a lot of OCD as happening alongside. People with bipolar may have panic disorder occurring or generalized anxiety disorder that may occur with them. People with various forms of medical conditions, For example, I mentioned some DVT, deep vein thrombosis, valvular heart diseases, people with malignant hypertension or severe and complicated diabetes mellitus may also develop forms of anxiety. You realize that increasingly diabetologists or endocrinologists are prescribing antidepressants to their diabetes patients. And they'll tell you they are using it to prevent diabetic polyneuropathy, but at the same time, they are using it to deal with the development of comorbid anxieties that may occur while they have diabetes. Any questions? Hello.
Yes, we are here.
Great.
Yeah, we are good.
We are following.
Yeah, any questions? Because I'm done. That's the last slide.
I think in the morning.
Hello.
Charles has a question. Charles has a question.
Thank you.
Excuse me.
Suddenly you woke up so many people, and they have a lot of questions for you.
There's a question here.
Okay.
Doctor, I want to find out with the mood disorders and then anxiety disorders, when it comes to its management, does color, music, aromatherapy play a role? Thank you.
These are adjunctive. They may suit one thing or the other, but they are not definitive. They are not.
So could we say we put those still under psychotherapy?
No, psychotherapy is specific. Psychotherapy is not just anything. Psychotherapy are designed therapeutic interventions that have you can do that have randomized controlled trials performed on them, just like you do with chemical treatments. Okay, and they have specific outcomes because there is a specific way of, just like you have dosing for drugs, there is a specific way of doing it and a regime with specific outcomes that come along with it.
Okay, thank you.
In the morning, we had this discussion around placebos versus chemical treatment for early stages of anxiety disorders. So in your practice, then in the early stages, do you avoid the use of medication, and what do you do?
I think that was for depression. Depression.
Yeah, the evidence that we have is that medication is as important as any psychological interventions, and both go hand in hand. So you cannot do, it's not either or. In the past, we've said that mild to moderate depression, you can you can use psychotherapeutic interventions. It still holds, but by and large, the combination of chemical intervention and psychological intervention has proven to be the best combination for outcomes. Yeah.
Hello, Doc.
I'm here.
What will you describe as anxiety neurosis?
Oh, it's an old terminology. It's obsolete now. We don't say anxiety neurosis. It's actually a tautology. We don't say that again. Now we talk about the specific types of anxiety disorders, not anxiety neurosis. It's an old term. We don't use it again.
Yes, but if you can educate us, what were they referring to as anxiety neurosis?
You know, in the past, they classified psychiatric disorders into two, the binary classification, where they had the psychosis or the psychotic disorders and neurosis or neurotic disorders. So conditions like schizophrenia, delusional disorder, schizophreniform were all considered under psychotic disorders. Then things like conditions like anxiety disorders, mood disorders like depression and the rest were considered as non-psychotic and therefore under what we call neurosis or neurotic disorders. So anxiety neurosis just is that's why I say it's a tautology. It means that anxiety which is non-psychotic or belonging to the class of neurosis. But now we don't say that. Our understanding has gone beyond that. And that's why I told you about the primary and secondary psychiatric psychosis. So we know that somebody with depression can actually develop psychosis as a complication. And therefore, you cannot place depression under a classificatory block you call neurosis, and that they never develop psychosis. So now we are looking at the individual conditions and the blocks. And that is what the classifications now look at.
Okay. Please, I
Hello?
think in the hello.
Please hold on. Hello, Doc.
Yes, I'm here.
I just wanted to find out whether our diet can have any effects on our these anxiety disorders or mood disorders.
Well, some diets. We know that some foods have impact on our moods. For example, recepin is a typical example of chemical agents and which were part of certain foods that generated or caused some form of mental health problems. So yes, it does occur if it has certain kinds of ingredients to. But I cannot think about immediate dietary content in our situation that would lead to that. You know, the antihypertensive Brenidine, which was made from the recepin-like, molecule, was causing a lot of mood problems. Now we don't use it.
Yeah, Doc, please. In the morning, there was a question that I couldn't get a clear answer to. That's the use of fluoxetine in patients with hemorrhagic stroke. That is a practice in CAP where quite a number of patients with hemorrhagic stroke are put on fluoxetine. So what role has that medication? Whether it would worsen the stroke, because fluoxetine has been found to increase the risk of bleeding. Thank you.
Well,
some point of correction. I think it was the use of fluoxetine in stroke, but the concern is the risk of bleeding in patients with hemorrhagic stroke.
Well, if it's a hemorrhagic stroke, then they are already prone to the bleed because it's the bleed that is causing the stroke now. And fluoxetine, known to exacerbate that or cause a risk of that. So I wonder the benefit it would have in people with hemorrhagic stroke. But those with thrombotic stroke, we know that a substantial number of them have mood problems, and it does help them. Once they get into depression, their response to treatment slows. Mind you, that depression, I didn't want to get you all confused. Depression is more than just a mood issue. Depression affects metabolism. It affects endocrine system. The sugar metabolism and lipid metabolism, it does affect it. So people with depression tend to have other forms of endocrine and other metabolic problems. And therefore, someone with a stroke, the moment they get into depression, a lot of other things are affected and medication response goes down. So that's one of the things that informs some of these things. But in terms of hemorrhagic stroke, I wonder if it would add any benefit in the acute phase.
Thank you very much. I think we are getting to the end of our long marathon. So we'll take a 10 minutes break if you don't mind, and then we'll come for the lecture on epilepsy. Okay.
Was that an anxiety disorder?
Okay. So, yes, can we take some 10-minute stretch break, and then we'll come for, it's an introductory lecture, in epilepsy, so that we can finish early tomorrow and then go.
Yeah, I don't intend to keep long on epilepsy, so.
Okay. So, Dr. Dane, we'll take some 10 minutes mobility break and come back for the epilepsy lecture.
Okay, thank you.